happening in health sciences. When it comes to movement disorder, we know that deep brain stimulation, which is there for last 2 to 3 decades, has evolved into a major treatment option for people who have got advanced Parkinson's disease. And we have a lot of innovations like directional leads. We have new softwares coming up. We have Illumina 3D, and then we have Brain Sense, and then Adaptive DBS, which is coming into picture. So I think we need to always keep in pace with all these technologies for us to go forward for offering the better treatment for Parkinson's patient. So today we have called the experts who are in the field of movement disorder, who will try to answer some of the questions, and we will also share our experience about a few cases of adaptive DBS, what we have done at Manipal Sarjapur Road, Bangalore. So today's session is going to open up some interesting topics, questions, some unanswered questions, and we'll try to see whether we can choose some of these best answers for taking the practice forward. So with this, I sincerely extend my greetings to all the people who are present here, who have come. Some have come out of Bangalore, outside Bangalore. They have traveled a long distance, and they have come on a Sunday to attend this meeting, which is a focused meeting for deep brain stimulation in Parkinson's disease. So it's my privilege to declare DBS Summit open. I wish you all a stimulating session here so that we take some insightful thoughts for our best practice in the future. Thank you very much. So I call upon Swati, who will first deliver the talk on how to uh, select a patient for deep brain stimulation. Swati is a consultant neurologist and she is a fellow in movement disorder from NIMHANS. She is working as a consultant.
At the outset, I would like to thank the Medtronic team and the Manipal Hospital Sarjapur for giving me this wonderful opportunity. It's a privilege for me to be here among this esteemed faculty of neurologist and neurosurgeon, especially in front of Dr. Pramod Kumar Pal sir and Vikram Hulla sir, who are my mentors and guides.
Yeah, sorry. I would like to call the distinguished chairpersons here. I would like to call Dr. Pramod Pal sir. We know Pramod Pal sir. He was there as a professor and movement disorder specialist at NIMHANS, and now he has joined St. John's Medical College, and probably he's heading the movement disorder section of St. John's Hospital. So thank you for coming. Thanks. I would like to invite Dr. Milind, who is a senior consultant neurosurgeon, who is from Manipal Hospital, Kolkata. Sir has got a lot of experience in deep brain stimulation. I welcome you, sir, for this session. And I call upon my colleague, Dr. Aditya Kulkarni. He is a consultant neurologist at Manipal Hospital, Sarjapur Road. Um, I thank you all these chairpersons to chair this session. Thank you very much.
So today I will be discussing on choosing the right patient for deep brain stimulation. So the roadmap for the next 30 minutes are why patient selection is everything based on the evidence-based factors which drive the DBS candidacy, the disease-specific criteria for Parkinson disease, essential tremor, and dystonia, the universal red flags for DBS surgery, and a practical pathway, a stepwise multidisciplinary algorithm which you can use in your clinic, and adaptive DBS and future patient selection. So why patient selection is everything? Appropriate patient selection is a major determinant of successful outcome with deep brain stimulation. So the predictor of a good DBS outcome is appropriate patient selection based on interdisciplinary evaluation, reasonable expectations from patients and family, accurate uncomplicated lead implantation, and optimal device programming. So we'll be discussing mainly on three movement disorders, and they have three different selection logics. So in Parkinson disease, the usual target is ST or GPI. And the common inclusion criteria is those with levodopa responsive motor features with disabling fluctuations or dyskinesia despite optimized therapy. Whereas in essential tremor, the target is Wim nucleus of thalamus in those who have disabling bilateral action tremor unresponsive to first line pharmacotherapy. And in dystonia, the target is GPI. And for those who have sustained or intermittent muscle contraction causing disabling posture or movement. So first, we'll discuss among the Parkinson's disease. So step one is to diagnose, is this really idiopathic Parkinson's disease? Because DBS is most effective for idiopathic PD and it is unhelpful in atypical Parkinson's syndromes. So what are the supportive features for an idiopathic Parkinson's disease? So there should be more than 2 out of 3 cardinal features like rest tremor, rigidity, bradykinesia, asymmetrical onset of symptoms or signs, sustained and substantial response to levodopa or dopamine agonist, and longer disease duration without atypical feature increases the diagnostic certainty. So, what all are the red flags for alternate diagnosis? Means atypical Parkinsonism. If there is prominent postural instability or freezing within first 3 years, or hallucination unrelated to medications early in disease, dementia preceding or within 1 year of motor onset, then supranuclear gaze palsy, upper motor neuron signs, severe dysautonomia. All these are red flags for in idiopathic Parkinson disease. So, what all are the inclusion criteria and exclusion criteria for a DBS candidacy? So, the inclusion criteria is a clear diagnosis of idiopathic Parkinson disease with disabling motor fluctuations or dyskinesia despite optimized pharmacotherapy and robust motor response to levodopa except tremor. Levodopa non-responsive tremor can improve with DBS and a clear understanding of risk and realistic expectation. And the exclusion criteria for DBS includes serious surgical comorbidities, uncontrolled psychiatric illness like anxiety, psychosis, or mood disorder, dementia, and preoperative MRI with extensive white matter change or severe cerebral atrophy. These are the exclusion criteria. So, during the pre-DBS evaluation, the most important test is the dopaminergic challenge test. So, during which we'll assess the patient after a 12-hour off medication overnight. Then we have to do the MDS UPDRS Part 3 off state scale. Then you should repeat after an levodopa carbidopa of a 250 mg. Then ask the patient what is their best state. If they're having the best on response, during that time, you have to do the MDS UPDRS Part 3 on state. At least there should be 30 to 33% improvement from the off state scores. Then that means those patients are a good candidate for a DBS. Key exceptions are medication refractory Parkinson tremor and severe dyskinesia or frequent on and off fluctuation. The point to keep in mind is symptom resistance to levodopa will likely be resistance to DBS too. Only those symptoms which improve with levodopa will only improve with DBS. So, which motor symptoms respond? The symptom which improve with DBS is tremor, motor fluctuations, bradykinesia, rigidity, and dyskinesia. The symptom which generally do not improve with DBS is hypophonic speech, dysphagia, micrographia, freezing of gait, especially in on state. If the patient has on state freezing, it will not improve even after DBS. And significant balance abnormalities. So next, in the pre-DBS workup, the most important thing is a cognitive screening. A formal neuropsychological evaluation is a standard pre-DBS workup in most of the centers. Those who classify the criteria of a dementia, most centers do not offer DBS because if a patient is already having dementia, there will be widespread disease which predict a poor motor response and difficulty in tolerating the awake surgery and device management. Those with mild cognitive impairment is not an absolute contraindication, but severe MCI needs an added scrutiny of a target and a surgical approach. Usually, those with comorbid dementia will opt for a GPI rather than an STN. Those with a normal cognition is the ideal profile for a DBS candidate as a DBS candidate. Next, coming to the psychiatric illness. So, if a patient is having a depression, mostly as we know, as part of a non-motor symptom in Parkinson disease, majority will have a depression, anxiety, and the prevalence is like 40 to 50%. So you can use a screening scale. The commonly used are the geriatric depression scale, the HAM-A, HAM-D, and the Montgomery and Asperg depression rating scale. According to the CAPCIT PD recommendation, a score ranging from 7 to 19 on the MADRS is an exclusion criteria. Coming to psychosis, active hallucination or delusion raise a post-operative psychiatric risk. If the patient's psychotic symptoms are mild and clearly medication-induced, then treatment with DBS may be beneficial because post-operatively we can reduce the medication. But if there is significant unresolved psychiatric symptom, those are a relative contraindication for a DBS surgery. So getting the timing right. DBS is now viewed as a means of maintaining function before disability accumulate. It is not an end-stage rescue therapy. So based on the studies published by the Rushel et al., where there was RCT in advanced PD, the STN DBS improved the quality of life and UPDRS 3 score versus medication alone at a 6 month. And in early STIM study, PD with early motor complication and preserved function in the group with STN DBS and medical therapy beat the best medical therapy alone. So coming to age and target selection. So age is a relative contraindication, not an absolute contraindication. There is no strict upper age cutoff. But for those who are more than 70 years, there is more risk for post-operative complication like delirium and high adverse effect during the surgery because those with severe cortical atrophy or severe significant small vessel ischemic changes, the surgical risk is a bit more. So in such cases, a staged unilateral first implantation reduces the delirium risk in older patients. So robust levodopa response and preserved cognition matter more than chronological age. Coming to the target selection, STN versus GPI. STN offers a greater medication reduction and it has a larger evidence based on studies and has a lower stimulation threshold. Whereas GPI has an advantage of a direct anti-dyskinetic effect and a better preservation of cognition and mood. So those who are having dementia or cognitive impairment with psychiatric symptom, GPI will be a better target compared to STN. There is no significant difference in primary motor outcomes on large RCTs. So we have to decide the target based upon the patient symptom profile and the non-motor symptom burden. So if you compare STN versus GPI, those who have dystonic features, postural instability, psychiatric comorbidities, severe dyskinesia, and advanced age, GPI will be a better target compared to STN. But those with severe tremor, severe fluctuations, and severe akinetic sign, relatively STN is a better target compared to GPI. Both target gives comparable motor benefit, so the tiebreaker is patient's non-motor and symptom profile. So coming to the screening 521 criteria, which is a screening tool for advanced Parkinson disease. So the general neurologist can refer the patient for a device-aided therapy or a deep brain stimulation. So 5 means 5 or more doses of oral levodopa per day, means escalating the dosing frequency reflects a shrinking therapeutic window and a worsening motor response, means motor fluctuation has started. Or 2 or more hours of off time per day. So a cumulative daily time with reduced or absent motor benefit despite an optimized medical therapy. Or 1 or more hour of troublesome dyskinesia per day. So this is a single positive criteria which signals advanced PD and time to refer. But the standard DBS motor medical therapy, sustained levodopa responsiveness or medication refractory tremor with no significant cognitive decline or uncontrolled psychiatric illness and with acceptable surgical risk. That should be there in the background, but this is this you can use like a screening tool to refer for a DBS ka pre-DBS workup. So coming to essential tremor. So essential tremor, the diagnostic criteria and red flags. So according to the MDS consensus statement on tremor classification, essential tremor definition is bilateral upper limb action predominant tremor. The duration should be at least more than 3 years with plus or minus tremor of head tremor, voice tremor or lower limb tremor with no dystonia, ataxia or Parkinsonism. There is a group called essential tremor plus where there will be all features of essential tremor plus soft neurological signs of uncertain significance, which is not enough alone for a separate diagnosis. So you can have questionable dystonic posturing, mildly impaired tandem gait or mild memory impairment. The red flags to reconsider the diagnosis of an essential tremor is associated Parkinsonism, dystonia, any other cerebellar or structural disease or functional psychogenic tremor. So before referring a patient for DBS, first you have to try with medical management. So the common first line agents are propranolol or primidone, and second line you can add topiramate, or some cases you can even use botulinum toxin. So if there is no, usually the first line choice is propranolol, primidone. If there is no significant improvement, you can refer the patient. If the symptoms are disabling in an activities to do the activities of daily living, you can go for a DBS. So in essential tremor, you should first optimize the medical therapy. After that, reassess the disability. If the tremor still limits the ADL, occupation or quality of life, or if the side effect of medications are intolerable, despite optimized medical trial, you can refer for device therapy. So usual device therapies available are the WIM thalamic DBS or MR-guided focused ultrasound thalamotomy for a selected unilateral cases. So usually in essential tremor, the main target is WIM thalamus. It is the only FDA-approved target, which is highly effective for contralateral arm tremor, both short-term and long-term. You can do unilateral or bilateral DBS, but in bilateral cases, you should see whether the patient requires bilateral, because the risk for bilateral WIM DBS is they will have a risk for dysarthria and imbalance in the future. Now coming to dystonia. So beyond identifying dystonia, the characterization of its type is essential to decide who benefits from DBS. So you should see whether the dystonia is an isolated or primary dystonia, where there is no accompanying neurological features other than tremor, and no identifiable structural causes, or a non-DYT1 or DYT6 mutation, because they are best DBS responders. Or whether it is a combined dystonia or dystonia plus associated with myoclonus, Parkinsonism or dysautonomia, or it is a secondary or acquired causes like structural lesion, perinatal injury, tardy or heterodegenerative causes. Usually secondary dystonias respond poor, exception is tardy dystonia, which will have at least moderate response to DBS. So which dystonia responds best to DBS? So the predictors of good outcome are the DYT-TOR1A, where there was an improvement in a published study. There was 64.2% improvement in BFMDRS movement score after 1 year. DYT SGCE myoclonus dystonia, they can also have a marked durable relief of both myoclonic and dystonic posturing. Limb or trunk predominant dystonia, they have a greater improvement than cranial or facial predominant symptoms. And isolated non-degenerative dystonia, those who do, if you do the surgery at a younger age and a shorter disease duration, they will have a favorable better outcome. The predictors of poor outcome are acquired dystonia, especially dyskinetic CP. Those who have done DBS, there was only 27% of them reached clinically meaningful response, and the improvement was hardly 20 to 24%. Then DYT TAP1 and DYT GNAL had a more variable or moderate response than a TOR1A. And cranial cervical facial predominant phenotype also consistently had a less response across the cohort. And higher preoperative anxiety is an independent predictor of poorer motor outcome in GPI DBS in a dystonia. So in dystonia, a model combining of genetic profile, motor symptom pattern, and clinical factors like age at onset, severity, and duration explains up to 81% of DBS outcome variability in dystonia, supporting we should do a genetic testing and phenotyping before surgical referral. So the target in dystonia is GPI, which is the gold standard target for most of the isolated and generalized dystonia. So in a dystonia, you have to do a genetic testing pre-DBS, then early referral. Ideally, it should be less than 5 years from onset, especially DYT KMT2B and those with acquired etiologies, to limit the fixed deformity and to offer maximum plasticity. Then you should screen for anxiety or psychiatric comorbidities, which you should address preoperatively, which are independently predicts the motor outcomes. Then set realistic expectation in acquired dystonia, because the improvement after DBS is not that good. So it will require a multidisciplinary care and have to continue medical optimization along with DBS in acquired dystonias. So the universal red flags across PD, ET, and dystonia is first, uncontrolled psychiatric illness. It could be either active psychosis, unresolved depression, or severe anxiety. Significant dementia. Why? Because widespread disease, poor surgical tolerance, and difficulty in programming. Serious surgical or anesthesia risk like uncontrolled hypertension, coagulopathy, or immunosuppression. unfavorable neuroimaging, where there is extensive white matter disease, severe atrophy or structural lesion, unrealistic expectation, like patient or family without clear understanding of realistic benefit, and inadequate social support. So these are the universal red flags among all the PDET and dystonia. So just a pre-DBS checklist for Parkinson's disease. So you have to first see why you are doing DBS in a PD, whether there is, first check for the indication, whether they are having a good levodopa responsiveness, disabling motor fluctuation, disabling dyskinesia, disabling tremor, or intolerance to medication. Look for the contraindication, any major cognitive impairment, major psychiatric illness, severe autonomic impairment, significant comorbidities, or lack of social support. Then rating scale, the important scale is the MDS UPDRS part 3. If you're interested, you can use the other scale like the PDQ-39 dyskinesia rating scale. MoCA is important, this SS screening. If the MoCA is abnormal, you have to go for a full neuropsychological assessment. Then other non-motor scale you can use. Then other investigation and consultation, you have to do all the routine investigation, autonomic function testing to rule out any involvement of autonomic dysfunction, ultrasound abdomen with post-void residual urine to see whether any evidence of same MSA is there. Then you have to do an MRA brain with DBS protocol, speech assessment, neuropsychology assessment, psychiatry opinion, neurosurgery consultation, cardiac clearance. So these are the checklists for a PD disease. So pre-DBS checklist for a dystonia, you have to look what is the indication. Is it a disabling dystonia, or you are doing because of the genetic diagnosis like a TOR1A which respond good with DBS, or is it like a palliative due to suboptimal response to medication in acquired cases? Contraindication, the same. Rating scale in dystonia, you can use BFMDRS, Twisters, UDRS, GDRS, MoCA, HAM-A, for anxiety, depression. Investigation and consultation, the same, general test. So pre-DBS checklist for essential tremor, again indication whether it is a disabling bilateral action tremor refractory to medical therapy, which is significantly affecting the activities of daily living like feeding, writing, hygiene, or occupation. Confirmed core diagnostic criteria for essential tremor, trial and failure of first-line medications, social or occupational disability for tremor. Contraindication, the same set, major cognitive impairment, major psychiatric illness, autonomic impairment, significant comorbidities, and lack of social support. Rating scale in ET, you can use TETRAS, Fantolosum Marine Tremor Rating Scale, Archimedes Spiral Handwriting Sample, Quest, MoCA, HAM-A. And for all the PD, dystonia, or ET, you have to do a video recording of pre and post. Then the routine investigations. So a practical selection pathway is confirm the diagnosis, optimize the medical therapy, quantify the disability, multidisciplinary evaluation, objective response testing, and shared decision and target selection, which are the factors which are the good predictor for DBS. So now coming to the new paradigm from continuous to closed loop stimulation. Usually the conventional DBS delivers a fixed continuous stimulation regardless of patient's fluctuating clinical state. So now the adaptive DBS, they will sense, interpret, and adapt according to the patient's need. So what are the advantages? From exclusion, it has become personalization. So the fixed parameter DBS forces conservative candidacy cutoffs, real-time biomarker feedback may let therapy fit the patient rather than the reverse, and potential to extend the candidacy. Patient with prominent fluctuation-driven disability, previously like borderline or conventional criteria, may become better candidates as programming becomes state responsive. Then energy efficiency and side effect reduction. So demonstrated reduction in stimulation time may lower stimulation-induced side effect, which usually narrow the candidacy. For example, dysarthria and gait effects. So regarding the adaptive DBS, Dr. Vikram Holla sir will be speaking in detail. So I will just go through one or two cases which we have done in our center who was a good patient, where we demonstrate a good patient selection, how they improve before surgery and after surgery. So he's a 52-year-old pharmacist who had a significant bradykinesia, rigidity with severe gait disturbance in the form of freezing. This is before surgery, whose total levodopa dose was around 1000 mg per day and had significant motor fluctuation with peak dose dyskinesia. This is after surgery, post-surgery video, where the gait has improved significantly, almost near normal, where he's able to move along with his routine activities. So a second patient who is a 55-year-old builder who had same severe gait disturbance with freezing and fascination, which was affecting his activities of daily living. So this is the post-DBS, where he's a builder by profession, where he's able to manage all his activities without much difficulty. So the key takeaways: selection is the single best lever on outcome, more than surgical technique alone. Diagnostic certainty and objective levodopa medication response drive candidacy in PD. Cognitive, psychiatric, and imaging red flags cut across PD, ET, and dystonia alike. A multidisciplinary stepwise pathway keeps selection consistent and defensible. Adaptive DBS won't replace careful selection. It will make therapy more forgiving of it. Thank you.
Thank you, Dr. Swati, for the excellent summary of indications for DBS. Shall we take some questions from the audience? Anyone wants? Yeah.
You mentioned that essential tremor is one of the indications. Essential tremor, we see that hand tremor responds well to the medical management compared to voice tremor or head tremor. So, what is the implication of DBS in this category of patients?
Yes, sir. In essential tremor, in all cases, first we have to try medical therapy. Even after trying the medical therapy, if the medication side effect is intolerable or they are not able to use the medicine, or even after medical therapy the response is not good and they are not able to carry out their activities of daily living, then you can give an option for DBS or the MR guided focus ultrasound.
Does it work equally well for a hand tremor and head tremor or a voice tremor?
Usually, basically, all these procedure we are aiming is to have an independent life. It doesn't completely cure the symptoms. So we'll be targeting more on a hand tremor rather than a voice tremor, because the hand tremor will be the one which is disabling to carry out a daily activity. So yeah, hand tremor will improve.
Can I answer that question for her? Basically, head tremor will improve after doing bilateral VIM DBS by about 30%. You will not see more than 33% improvement. And if you have significantly high head tremor, then you should position the lead a little bit more medial because the head area is more medial in VIM. But the best option for head tremor is Botox in neck muscles. That is much better than DBS. And same for voice tremor. Voice tremor will never improve with DBS. The best option is to give the transarytenoid Botox to the vocal cords. That will improve the voice tremor. So if that is the only indication, head or voice tremor, you will not recommend DBS.
Because we often, general neurologists, we often try the medication at a higher dose for these two categories. We get frustrated
Right.
because they don't respond that well as compared to hand tremor.
Yeah. So for head tremor, try Botox, bilateral neck muscle Botox. And for voice tremor, try the vocal cord Botox. That will improve.
Yeah.
So you told exclusion criteria is psychiatric disease. Is it absolute or can it be managed and then we can?
Yeah, so first of all, if it is a drug-induced, as you can see, all the dopamine agonists can cause as side effect hallucination. Even Pacitine can cause hallucination. If it is a drug-induced psychiatric symptom, yeah, you can do, because after DBS we will be able to reduce the drug dose. So the psychiatric symptom, it is drug-induced, it will improve. But if there is a underlying severe psychiatric symptom, which with medication also it is not controlled, generally, because ST and DBS will worsen the psychiatric and cognitive symptoms. So if you want to do, if the motor symptoms are disabling, you can opt for a GPI rather than STN.
But should
It's
we
not
put
an
it,
absolute
no,
contraindication,
should we
it's
put
a
it in that
relative.
exclusion criteria? That's what I wanted to know.
Can I answer that for you, Dr. Swati? It's not an exclusion criteria, but you have to make sure that this is not organic psychosis. This is not something like LBD or some kind of atypical. And that is one of the criticism for early STIM. In 2 years after Parkinson's symptom, when you start doing DBS, you don't know what animal you are handling. So it's better to wait and see how things evolve. But as far as the psychiatric issues are concerned, if it is major psychosis, then I'll stay away from the patient. Or I will do GPI. I will not go to STN, because in patient with psychiatric disorders, even well controlled, the post-operative delirium is about 40 to 50%, and it's hard to manage these patients and the families more than the patients. So not absolute contraindication, but be careful when you do that.
Most of the centers now are switching from STN to GPI. In this era, you feel that criteria is applicable? That's what I wanted to know, sir.
For psychiatric...
No, for Parkinson's. Many centers are doing GPI, if I'm right.
I think this is an old debate, and the VA study did, and Kim Burchell did the open study. And when I started doing it in 2000, early 2000, Jerry Wittek was our neurologist, and he was a big GPI guy. Melvin D. Long, Jerry Wittek, these were big GPI guys. So I'd done lots of GPI. But over time, I realized if the patient is young, and if the symptoms are, as she said rightly, tremors, akinesia, standard Parkinson's symptoms, and high dose of levodopa, better to stay with STN, because STN has a better result, better symptom reduction, better dose reduction, better lasting benefits. But whenever there is an issue with cognitive issues, even MCI, minimal cognitive impairment, or the symptoms are dyskinesia, and dyskinesia at a low dose of syndopa. Half syndopa gives you dyskinesia, and never go to STN, because programming will be a nightmare. So go to GPI. So you have to select patient by patient. There is nothing GPI better, STN better. For that patient, what is better, you got to select. And I think she outlined that pretty well in her talk.
Parkinson's disease for, referring for DBS, YOPDs? Would you still wait for the drug-induced dyskinesia on and off effects, or would you refer them early for a DBS?
If you have the genetic diagnosis, anyway, all the young onset PD will send the genetic testing. So in that genetic testing, if the mutation like Parkin, which will respond good with DBS, I think you can go early. You don't have to wait.
Can I make a comment on this, what
Yes.
you asked?
Yes, sir.
See, young onset Parkinson's disease, those who have genetic diagnosis, especially some type of NBA disorders and all. And it is better to wait a little, because there, many times patients will have dystonia and psychiatric problems. And there, your selection of the cases also, GPI may be better. And over time, there could be progressive course. So it is better to wait for some time, because young onset, typically these patients, like we have experience with the Parkin, Plateau G6, and GBA mutations, all this. Okay, so if there is, because they have to have a long lifespan. It is not that, except for the PLA2 G6, they can have a rapid deteriorating course, even if you do a deep brain stimulation. So it is better to wait for those.
Yes.
And yeah.
So exactly, it's a fine balance. In YOPDs, exactly when to go for DBS and when not to. As you said, they have a progressive course, they can get dyskinesias. Mm-hmm. So we have to have a common consensus as to what is the timeline for YOPDs so I can be referred for DBS surgeries. So
yeah.
that's something.
Consensus, I don't think, unless you have large cohorts of patients with mutations of Parkin or GBA or Plateau G6. They are the three common ones which we find in India. Vikram may just give some idea, because he was working in this area. Yeah, what is our experience in NIMHANS about the
unlike dystonia, where if it's a genetically mediated dystonia, you should always go for early, not wait for the development of all the sort of fixed deformities. In PD, I think genetic will not decide when the patient would go for a DBS. It will again go back to the disability, dyskinesias, fluctuations, tablet requirement, all those things. The genetic may sort of decide which nucleus to go for, what is the long-term prognosis, how is expectations, all those things in the counseling, rather than, per se, whether the patient should go for, also in certain cases, whether to go for DBS or not, if the genetic disorder is quite rapidly progressive and we don't expect good quality of life extension in the particular diagnosis. Regarding, as sir was mentioning, some of the genetic, although literature says, good response, sometimes we may have, like Parkin and all, there may be sometimes dyskinesias may worsen. GBA1, they also can have early cognitive impairment, although it may be because of disease progression, but still not sure. So genetic, whether to have, and again, genetic testing is not essential before going for a DBS. If a patient refuses genetic testing, we still have to evaluate the patient, and not a compulsion that they have to go for a genetic testing. It's an option, and we still have to treat the patient similar to a genetic negative or a patient. So it is still come back to the clinical phenotype rather than the genetic diagnosis. Diagnosis matters after, the counseling and the long term.
So in our experience in that GBA mutation group, so if you get a diagnosis, I think it is better to go for a GPI because of the later on cognitive dysfunction and all. Anyone else want to speak? Yeah.
Regarding young onset Parkinson's, I think GBA, LRK2 and Pinky. The three, they're favorable for DBS.
LRK2 is hardly found in India.
Yeah,
Okay,
agree.
so Parkin is one of the most important ones
Yeah.
which is found. GBA and
Yeah, and regarding GBA, as you said, the GPA is the preferable for better than STN. Of late, they have done the functional studies. They found the nuclear ambience atrophy should be contraindicated for GPA, even GPA also, because they can induce psychosis later.
okay, if there are no more comments, then okay, can you?
Now next I call upon Dr. Vikram Hola to deliver his talk.
This is just a brief introduction of Dr. Holla, who is an adjunct professor now at NIMHANS, and he is one of the pioneers in leading the group of patients with DBS and genetics. So he has subspecialized in genetics as well as DBS, and definitely he will give you an idea about the adaptive DBS.
Yep. Thank you, sir, for the introduction. And I thank, at the outset, I thank Dr. Ajay for giving me this opportunity, and also Manipal Hospital. And I'll be talking on the adaptive deep brain stimulation. Is it going to change the practice? So basically, I want to disclose certain things, like I have used AI for certain slides and mainly collating the data, and also for the better representation of the images. And I have no conflict of interest. And I'll mainly be focusing on aDBS and PD, because that is where it is approved and where we are sort of interested in currently. And my talk will be mostly based on the literature. Unfortunately, I don't have enough experience right now to comment on the personal experiences aspect. There is a panel discussion and the case discussion. Maybe we can have a more discussion at that point of time. So my outline will be it will be on the evolution of therapy in PD, why we reached aDBS, and what are the LFPs, because that is what the aDBS depends on, and what is aDBS, and what are the current studies, that pivotal trial that is Adapt PD, further other studies, that are small studies that are there, and what are the, how is it going to change our clinical practice? So coming to, over the years, starting from the first lesioning as a part of treatment for PD, so every new modality of therapy has sort of helped the patient, but later on realized, okay, this is not everything, and there are a lot of limitations. And every subsequent mode of therapy has been sort of driven by the limitations of the prior mode of therapies, like for instance, the lesioning because of the unilaterality and the permanent, and levodopa came, but it lasted for some time because of the dyskinesias. Then again, stereotactic functional surgeries, then alternative other group of medications, including the device-assisted therapies and all, MR-guided FUS, then came the DBS, which for many years, it has been very helpful in sort of improving the quality of life of the patients and the family members. But every one of them have their own limitations, which led to the sort of research into the what extra can be done for the patients. So in that aspect, the aDBS is sort of offering those patients who are doing well on continuous DBS, but still not achieving the maximum potential. That is where the aDBS is sort of helping in furthering that, further improving the quality of life. So the local fit potential, that is, basically it is sort of rather, when we record the MER, it is very fine, very few or single or very few motor units that will be recorded. The neuronal circuit will be recorded. Whereas LFP, it is like and we are standing in the stadium and we put a mic in the center of the stadium, you can listen everything, but you can go to individual person and listen to that person. So this is how the LFP work. So it is the summation of all the activities that is surrounding region rather than the individual or very few neuronal fibers. So I mean, there are different sort of based on the frequency, delta, theta, alpha, and then comes the beta, high beta, low beta, gamma. So there are various local potential frequencies that have been identified, and many of them have been identified with certain sort of features. Like for instance, the delta mostly with the tonic dystonias, the theta alpha region maybe with the tremor frequencies. The beta is where the alpha beta frequency is where the PD related bradykinesia and rigidity. The gamma frequency with chorea and motor fluctuations, dyskinesia, sound time, and so on. There are various frequencies where the study is being going on, and currently the beta frequency is the most sort of reliable and sort of very helpful for the modulation of the treatment. So that is what sort of and even in PD, like across the diseases, like I mentioned, the phenomenology wise, and this is the disease wise. Even in PD, the beta is where we usually focus for the bradykinesia and rigidity. But there are other frequencies in the gamma. That is especially the stimulation. I forgot the. So the high gamma or the beta burst duration, which again sort of can be a proxy for the motor fluctuations. The gamma frequency can be a proxy for good motor control, prokinetic activity, and increased dyskinesias. So, and gamma frequencies again is a lot of research is going on. Maybe the next upcoming thing for the aDBS. After the beta frequencies. So just to make sense, whenever we record the LFUs, this will be very haphazard and sort of polyphasic sort of discharges, which will go through the Fourier transformation to identify the superimposed alpha activity, beta activity, and this all will be done by the processor. And then we'll get a graph that is sort of like this. As you can see, there is the initial will be alpha, theta, then beta, then gamma. So we will be focusing on the frequency of our interest, which may be a proxy for the symptom or the sign of our interest. Like for instance, in PD, the beta activity, sort of is a proxy for the rigidity and bradykinesia, and beta frequency comes down, the beta power comes down whenever the patient is treated with the medication or the DBS. So again, this is the same slide. Like for instance, as I mentioned, the dystonia is usually in the theta frequency. There are a lot of studies that says tonic dystonias have increased activity or the synchronization in the theta range. And whereas the phasic dystonia have a slightly on the higher frequency, that is the delta range. The beta range is where the bradykinesia and also rigidity. The tremor again in the theta range, sort of in the thalamic, it may be synchronized. And the dyskinesia is in the gamma range. Low gamma or high gamma sort of synchronization can happen in dyskinesias and also in the patients with good motor fluctuations. So whenever we say in the system, in the Medtronic system, we can see this as the peak again. We are interested in the peak that comes in the beta range, like for instance in this 16 Hertz, and 2.32 is the amplitude of that peak. And when we say power, it is the area under the curve, 5 Hertz around this particular peak. So that is why the number is different. So this is 2.3, 2.4, 1.5, whatever that comes is the peak amplitude. Whereas when we see the LFPs, the power, when we are setting the high threshold and the low threshold in the Medtronic system, so it will be the power, that is the area under the curve that will be referring to. So how is it sort of, what is the adaptive in the adaptive DBS? So basically in the conventional DBS, we used to set the system and we used to set the stimulation, which used to be continuous. Like, whether the patient is sleeping, awake, taken medication or not, the stimulation remains same and only can be changed externally by either the patient if we have given the limits or by the clinician. Whereas in the adaptive DBS, because the beta rhythm has been in multiple studies seen to be a proxy for a higher rigidity and bradykinesia and has been seen to get suppressed, the beta power gets suppressed with medication and also with DBS. So it is a very good sort of biomarker for monitoring the response continuously every second to second. So that is where the adaptive DBS is the system adapts to the biomarker, that is the beta power, and accordingly based on the settings that we have kept, will either increase or reduce the stimulation based on the beta activity. So that is where the adaptive sort of part of the DBS. So as I mentioned, the continuous is open loop. Open loop is in the sense there is we are there in that loop and we are going to change it. Whereas in the closed loop, there is a feedback system which the processor identifies and acts accordingly and again sort of changes the system and again asks for the feedback. So it is a loop is closed and the system is sort of acting on, I mean, by itself without requiring an external sort of role. I mean, as long as the system is working and we have set the limits properly. And the clinical evidence, currently the adaptive DBS is still evolving. We continue to have, I mean, continuous DBS has gone through a lot of studies and, I mean, a lot of, duration we have, patients we have, so we definitely know that continuous DBS helps. Whereas the adaptive DBS, there are a lot of studies coming up, but still it's in the early stage, and that is what I'll be sort of discussing about. So, I mean, why beta band oscillation became the sort of target signal, as I mentioned earlier. So it is, I mean, it also reflects the severity of the disease. I mean, duration of disease, it correlates with the severity of the disease, it correlates with the bradykinesia and rigidity. It comes down when the medication is taken and on time is good. It also comes down when the DBS stimulation is given. So it is a very good, and it is almost, I mean, replicable in multiple patients, it can be recorded. And so it is one of the very good biomarker for someone to sort of involve in the closed loop systems. So that is the reason why beta sort of beta power is being used for the adaptive DBS currently. Whereas the caveat is, I mean, although I mean it is a very good proxy, but still it is a lot of artifacts are there and lot of sort of processing needs to be done, and sometimes the actual beta gets sort of lost in the artifact processing. And it does not capture everything, only the bradykinesia, rigidity, the tremor, gait, postural instability, non-motor symptoms. Still, I mean, lot of things are there in PD, not only bradykinesia and rigidity. And also, I mean, the variation of the day-to-day variation cannot be, it doesn't take care of all the variations. It just shows up to 15 to 20% of the day-to-day variation and the inpatient, I mean, the patient-to-patient variation. And also sometimes it may be absent, especially in the immediate post-op period. So not all patients have beta activity despite the lead being in the perfect place. So, but I mean, in the majority, I mean, it is also, I mean, a good indicator that whether the lead is in the dorsolateral STN or not, because if it is there, then in many you should get a beta peak, but it is not always. Even in the imaging confirmed well-placed lead, also sometimes the beta peak may not be there, and especially in the immediate post-op when the impedance and all is sort of in the highest stage. So this, so coming to, I mean, just certain things that I'll just be introducing, like, because to understand what is adaptive DBS. So in the adaptive DBS, we can do let the system adapt to the biomarker either by what you call as a single threshold or a dual threshold. When you say it is a single threshold, it is also called as a fast responsive, because there is a threshold, one line. So as soon as the beta power goes above that level, the current will also increase. And as long as the beta power comes below that level, the current also, I mean, the stimulation also will decrease. And this happens at very fast, 250 millisecond range. And whatever limit we have set, the upper stimulation and the lower stimulation. So it keep on fluctuating up and down, as you can see. And in this. Whereas in the dual threshold, as soon as the beta power goes above the upper threshold, the current increases. And as soon as it comes between the two thresholds, there is a constant. I mean, the current doesn't increase anymore. It will maintain at that level. Till, I mean, anytime the waves again goes above the threshold, again the current will increase. And again, it will reach up to a maximum limit that we have set. So again, as soon as the beta power comes between the thresholds, again the current will maintain at that level. So it will not come down. And only the current will come down only when the beta power comes below the lower threshold. So this is the there is a two thresholds that are there in dual threshold, and the system tries to maintain the beta power between these two thresholds. Whereas in the single threshold, it is like a yo-yoing. As soon as the power goes above, the current increases. As soon as it comes below, the current decreases. And it is very rapidly done. Whereas in the dual threshold, it is usually very slowly. The ramp up happens in 2.5 minutes and the ramp down happens in 5 minutes. So it is done very slowly, whereas the the single threshold will happen within a second. 250 millisecond ups and downs keep happening. So this is how, I mean, in the system it appears sort of. This is the single threshold. As you can see, as soon as the peak goes above, there is a sudden increase in to the top stimulation, and as soon as it comes down again, there is a current dip to the lower limit. Whereas in adaptive stimulation, I mean, the dual threshold, it remains so, and only when it comes down, and also after for a particular time, it has to be 1.2 seconds. I mean, it has to last at that level, because there may be a lot of fluctuations. So it will wait. It is a bounce period. It will wait for certain time before it sort of starts acting on the crossover of the beta power to the above or below threshold. And as you can see, I mean, So here the left STN and the right STN, this is the LFP. So this is the midline, this is the upper threshold and lower threshold. As you can see, it is trying to maintain in between, whereas the current is increasing. Although it looks like it is within the line, but still why the current is increasing. Whenever you see this sort of screen, this is not actually the individual time point, it is a 10-minute average. So that is why within that 10 minutes, there might have been multiple instances where the beta power had gone above, that is why the current has increased. And this is the sleep time where you can see the current is almost at the lower time. So with the adaptive stimulation, so and this is also the system, to show that this is the time when the current is in between the threshold. This is when the current is above the threshold, the beta power is above the threshold and below the threshold. So basically, with the adaptive threshold, especially the dual threshold one, what we try to do is, so there are every one of you have done a DBS, especially in STN DBS. You might have seen the patient comes in off state, you do the setting, the patient is very good, you ask him to take a tablet and come back, then the patient will be having severe dyskinesias. Now you don't know whether to reduce the medication or reduce the stimulation. So if you reduce the stimulation, what's the point of doing the DBS? But if you reduce the medications, maybe in the off state, the patient may not be that good. They still continue to have the fluctuations. So this is where the adaptive DBS maximum application comes. So with the adaptive stimulation, you can, set a higher sort of upper stimulation. So which means that is the stimulation that will be active for a off medication. So that is the maximum stimulation, you set an upper limit, and a lower stimulation in the on medication time. The lower stimulation is when the patient is sort of in the on phase. Lower stimulation is required to prevent the dyskinesias. The upper stimulation is the one, it is good effect but not having side effect, the maximum limit. And the lower limit is when the activity starts, that is the lower limit, or in the onset when the dyskinesis doesn't happen. So with the adaptive stimulation, what happens is, whenever the patient is having good effect, the beta power comes down and the current also comes down, so that at that point of time, there will not be any dyskinesias. Whereas when the patient is going into the off state, when the medication effect is going down, the beta power will start increasing. That time the stimulation again will increase, so that to account for the reduction in the drug dose. So again, the patient's stimulation will change, as per the, patient is in the on state, off state, or patient is having dyskinesias or not. So this is what the major role of adaptive DBS in managing the patients. So this, I think, again, in the next workflow, they will be discussing more. I just wanted to, so this is how, various parameters that will be seen. The maximum amplitude, the minimum amplitude, this is the limits where the 3.4 is what the maximum amplitude it reaches during the adaptive stimulation. 1.9 is what the minimum stimulation amplitude it reaches. 1.9, this is when the patient is in on state, or this is the stimulation where the effect starts, good effect is there. And 3.0 is where the effect is still there, but there is, the maximum you can reach without causing side effect. And this is the pause amplitude. Whenever some person doesn't want aDBS with pauses, this is the amplitude that it sets to. And there are various, the thresholds that again, in the next slide, this one it will be discussed. So basically, how did we reach the adaptive? So there are a lot of pilot work that happened, and then sensing capacity, because for LFP record has to be done before going for the closed loop. ADAPT-TB trial was the pivotal trial which was the basis for the FDA approval, and subsequently there are multiple other trials that are sort of, not trials, but smaller studies that have been done in the real world scenarios, and also in India, 2020, this year it was approved in India also, the adaptive DBS. So this is the pivotal trial, where the studies, so this was the, the flow chart, where the patient is already well maintained on continuous DBS. So it is not, adaptive DBS is not for someone who has just now underwent DBS and immediately you start adaptive DBS. It is for those patients who have already managed well. You have reached a stage where the continuous DBS is giving good benefit, but there are certain things, the fluctuations are happening, dyskinesias are happening. So it is not immediately to start adaptive DBS. You have to maintain the patients first on continuous DBS. And also the criteria was there should be at least 1.2 microvolt peak should be there before, this study, before they included the patients for the continuation. And this was just a non-inferiority trial. It was not a superiority trial. This was done to show the, the safety and the feasibility of adaptive DBS in the, general, like sort of in the real world scenario, rather than it being a sort of efficacy driven. So that needs to be understood, because this trial is just a non-inferiority trial. And there was no blinding from continuous DBS to adaptive DBS, but the blinding was there between adaptive DBS dual threshold and the single threshold. And 68 individuals were included, and ultimately, 30 were randomized to, and also both the dual threshold and single threshold were tried in each patient. Those who, tolerated both the, paradigms, they were, shifted for first 1 month for the dual threshold and next for the single threshold and vice versa. If someone did not tolerate any one of them, they were put only on the paradigm that they were tolerated. So with that, actually, out of 68 participants, almost 33% were excluded because either they did not have beta peak or they did not tolerate the aDBS, and they did not choose aDBS. And also, 44% of the participants tolerated both. Only 44% tolerated both the paradigms. So this is the real world sort of challenges that we will face. Not all patients we may be able to put on adaptive DBS. And as I mentioned, it's a multicenter single-blind crossover pivotal trial. And both ST and GPA DBS 1.2 microvolt peak, beta peak should be there. Then only they included. And so the feasibility, it was a feasibility study. So basically, again, to the primary endpoint, if you need to know, the primary endpoint was at least 50% of the patients, if they, after shifting on to adaptive DBS, did not have a reduction in the on time without troublesome dyskinesis more than 1 hour. So even if the patient had a worsening after aDBS but did not worsen more than 1 standard deviation or more than 2 hour loss of on-time non-troublesome dyskinesia, then also it satisfied the primary endpoint. It is not that all the patients of adaptive DBS did well compared to the continuous DBS. So this is the primary endpoint because it was a non-inferiority trial. And as you can see, inclusion also 85% on medications had beta peak, that is signal, and 65% only had beta peak bilaterally. So there are 35% patients who may not have beta peak bilaterally. This is again a challenge that we may have to face in the day-to-day activities, but it was better in the off-medication stage. And again, as I was mentioning, there are no peaks was on medication in 10 subjects and off medication 5 subjects, which was despite confirming that the lead was in place. And the frequency also, it was not always same, like it ranged from 8 to 30. And as you can see, the amplitude also, it was up till 8 to 9 also, but majority of them had 2 to 3 around. And this was the primary sort of endpoint, which they said 92% of the single threshold adaptive DBS and 95% of the dual threshold adaptive DBS satisfied the primary endpoint. In the sense, they did not, either they did better or they did not do worse than more than 1 standard deviation down, or in the post-hoc analysis, they modified it to, they did not do worse more than 2 hours lost in on-time non-troublesome dyskinesias. So this graph will show you, better. As you can see, this is what compared to the cDBS. So only proportion of the patient did well with aDBS. There were a proportion who actually, did not have a improvement in the on-time, non-troublesome dyskinesias, that is -2, that is 2 hour loss. There are some patients who lost around 1 to 2 hours of on-time non-troublesome dyskinesias. So because it was non-inferiority trial, they just wanted to show that adaptive DBS is feasible and it is can be applied in the real world scenarios. There was on an average improvement in the both in the single threshold and dual threshold. There was around 1.3 hours and 0.7 hours increased on time without troublesome dyskinesis on the average. But we need to understand that in 13 had a better outcome, whereas 16 worse outcome in single threshold, and 22 did better and 13 worse in dual threshold. So not all patients will do well. So because in the real world scenario, we expect that everything should be good. So but we should understand that there are some patients who may not do well with adaptive DBS as well, and that is even in the studies that has been shown. So this is the the major table, and again, the other secondary objective was the reduction in the total energy delivered, because the adaptive DBS adapts to the requirement of the patient's day-to-day requirements. So the other second objective was the current delivered will be reduced so that overstimulation is controlled, and also the longevity of the battery will be more. So this also, again, the mean difference was around 22, I forgot the unit. So but there was on an average 13% with single threshold and 11% is dual threshold aDBS. But this may come down further because more and more demanding and sort of a more sampling rate, the current utilization will increase. So this may not translate the same in the real world scenario. But on an average, many of the studies have shown that the total energy delivered is less, the longevity is more for the battery. After that, I mean, there are multiple other trials that have come, not trials, but smaller studies that have come, like this is ADAPT Milan cohort study. So this was, again, not a randomized or anything. They screened 20 subjects, but only 9 were eligible for various reasons. So you can see in a real world scenario, not all patients may be eligible, but and there was 35% greater unblinded MDS UPDRS3 improvement versus continuous DBS. So those patients who were selected, they did have a 35% improvement. So it is, I mean, it is like just a clinic representation, like every one of us are doing, like what is our, it is just sort of in a similar manner rather than a very controlled scenario. Another one was the chronic adaptive deep brain stimulation by Bush et al. So again, 8 were enrolled, 7 completed programming, out of which only 3 showed significant difference out of 7. So 4 did not show significant difference, but not significant means maybe the study was not powered enough. But surprisingly, 6 out of the 7, they chose adaptive DBS and told they will continue on adaptive DBS. So this was also in the adaptive trial also, despite having worsening in the, I mean, total on time without troublesome dyskinesias, still the many patients chose adaptive DBS because there are many other parameters, maybe the scales and what assessment that we are doing is not able to catch. The patients were satisfied with the adaptive DBS rather than going back to the continuous DBS. But it was not blinded, so maybe there will always be a bias as well. And this is another by Tanimura. This is the only blinded trial comparing cDBS and aDBS. And with this, and again, only 9 patients, they could not find any significant difference compared to cDBS and aDBS, but the study sort of number was very small compared to 62 in the ADAPT PD. This was only 9 patients. What they saw was both, I mean, certain aspects favored continuous DBS, like the total on time was favored in the continuous DBS, not statistically significant, whereas the UPDRS scores and the troublesome, non-troublesome dyskinesias, the troublesome dyskinesia in these patients favored adaptive DBS. So again, I mean, still a lot of information is required, but most of the studies say that in a subset of patients, the adaptive DBS definitely help in managing the fluctuations and the off states that they have when the medication effect is wearing off. And this is the Delphi consensus study where DBS expert, this was just before the ADAPT PD trial report came. So majority of them agreed that there was a consensus that this is going to be a clinical routine in the coming next decade, and it is already sort of becoming a clinical routine nowadays. And the major area that needs to be sort of sorted is the which patient benefit and what is the paradigm that or the protocol that has to be followed. These are the 2 main things that, I mean, we need to sort of focus on. And this is the ongoing another ADAPT PD Chinese study, which is sort of started in 2026 and 2027. Maybe we can expect the results. And it is again a larger study compared to the smaller studies that are that I shown so far. So the candidacy. So who are the candidates for adaptive DBS? So adaptive DBS can only be done if the sensing is available. The patient should already, I mean, have a sensing capable system and should be maintaining well on a continuous DBS at least for a couple of months. I mean, it is not that immediately you start the adaptive DBS as soon as the patient is out of the operation theater, or first instance itself when you're programming, you start adaptive DBS. So the patient should have a maintaining relatively well on continuous DBS and should have a recordable beta peak in at least one contact and at least in one side. So who are, if the patient is having tremor dominant phenotype, gait abnormality, postural instability, so these are still not sure how sort of adaptive DBS is going to affect them. But especially now, I mean, the bradykinesis and rigidity is sort of, most of the patients who have those can be managed pretty, I mean, good, or I mean, can benefit from this adaptive DBS. So what has changed? So what genuinely, I mean, like there is a FDA approval. Earlier it was all research, but now there is a clinical availability, FDA approval, Indian approval is there, so it can be offered to the patient on a clinical basis. There are a lot of hypothesis and strong reason why adaptive DBS should work. There is, I mean, a lot of studies are there, I mean, that supports adaptive DBS. So, but the study that is there mostly like non-inferiority still, the superiority studies, scale-based studies, and completely blinded cDBS or aDBS is still lacking. So we still have to get enough evidence before saying that aDBS sort of surpasses continuous DBS in every aspect. So, is it going to change the clinical practice? What is going to change? So definitely in the patients who are on continuous DBS, they're doing most of the time okay, but when the medication they take, they have dyskinesias, or when the medication time is due, they are going into off state. Those are the patients maybe you have to look for adaptive DBS and set them for that. The less dyskinesias during drug-on phases and fewer chronic overstimulation side effects. The speech impairment and a couple of studies, the gait also improved because of the reduction in the overstimulation. Along with that also increases our expectations, patients' expectations, the family members' expectations. Nowadays, everyone expects that because there is adaptive DBS, everything can be taken care of. So that expectation also changes now, so that we need to be sort of cautious about, because we also expect adaptive DBS is there, it will do wonders. Even with the continuous DBS also, we have patients who are not doing so well as expected. So same with any other technology, the patient brain is very sort of, we cannot predict, what is going to happen, but we can expect that majority do respond, but not all. And also the benefit and cost. So the added cost of the instrument, the added cost of the visits, so that also sort of changes a bit. So what are the challenges? So when the directional lead came, that it was like, okay, whatever the placement is, directional lead will take care. So that is not the point. Again here, we may assume that adaptive DBS is going to be a substitute, or maybe will help us out, help us out whenever the lead is not properly placed. That it cannot do. And the long-term real world, what is the outcome is still not available. What is the cost-benefit ratio? Disparity, sometimes some patients want this only because of the adaptive DBS. So what is the patient expectation? That is also a challenge. And time to optimization. We used to say, okay, 1 to 3 months you may take for the DBS, in the continuous DBS, to get a reasonable sort of a balance between the drug and the stimulation. Now you may have to add another 2-3 months for the continuous DBS, then again call them back for the timeline, and then set the adaptive DBS and again adjust it. So the optimization time may increase. That is again a challenge. And how the non-motor symptoms, gait, postural instability, freezing response, and in adaptive DBS, still there is a lot to be sort of understood. And beta activity, although multiple studies have shown that over the years it remains stable, but we still don't know how it is sort of going to change over time and how the response to the medication and DBS change. So what does not change? The first presentation, it doesn't matter whether you're going for adaptive or continuous or whatever, the patient selection remains the same. We cannot say this patient, before I did not offer you surgery, but because adaptive DBS is there, I may think about surgery now. No, that remains there is no, way that the patient selection can be lenient on patient selection, lenient on surgical procedure, and indication and contraindication, pre-DBS evaluation process. So all this remains the same. Even after the DBS also, the initial programming, continuous DBS, till that point it remains the same. We cannot substitute those with adaptive DBS. And also the proportion of patients who are doing relatively well with continuous DBS will also remain the same, because adaptive DBS may help additionally those patients who are otherwise doing well but are having certain challenges with respect to the fluctuations and the off-state time. But if someone is absolutely not doing well at all on continuous DBS, I don't think the adaptive DBS may also, currently there is no data to say that patients were not doing well at all on continuous DBS. Those were doing well on adaptive DBS. So that is still, not possible as of today. And the post-op programming core skill requirement for all those things still remain the same. So there is no change in those. So it does not remove the need for skilled programming. Still, we have to, it is not like AI or anything, still it is actually, there is a lot of extra learning curve, because even now, after doing so many DBS, continuous DBS, still we have the challenges of certain cases where we don't know where to, you raise the stimulation, there will be some problem, increase, there is dyskinesia. So we are still facing the challenges despite having experience of continuous DBS for so many years. So this is a new, modality, so there is a learning curve, there are a lot of uncertainties, a lot of things that we don't understand, so we have to be cautious about that, and we should acknowledge that and move forward rather than thinking that adaptive DBS is going to cover everything. It is not, it is definitely proven non-inferior and it is feasible, tolerable with a matching side effect profile, but it is still not proven to be superior to continuous DBS because there are no studies. The next studies will be, targeting on that, and the evidence is still young. And the practical barriers, as I mentioned earlier, the complexity, again, there is additional complexity. We still do, there are a lot of questions that are difficult to answer. So we don't know certain things, how the ramping up happens, or what is the ideal stimulation, ideal upper limit, lower limit, ideal LFP. So, the thresholds, all those things. And the time it takes, again, it is a barrier. You have to ask the patient to come again and again for the adaptive DBS as well, additional to what continuous DBS would offer. After the optimization, we used to call the patient once in 6 months, once in a year. Now, again, for another couple of visits, we may have to call them for the adaptive DBS. And the cost, again. And the other thing is, adaptive DBS is not advanced programming or automatic programming. The time sometimes may take extra. So that also we need to be aware about. And there are other platforms also, in sense, the sensing itself has helped a lot in understanding additional parameters to know how the patient is doing based on the timeline. The beta peak itself can help in also in shortlisting which contact to stimulate, so thereby reducing the time required for the initial programming. There are image-based programming and AI-based programming modalities also, and many of the other systems are coming up with sensing. So it definitely adds to the modalities that we have to improve the quality of life, the aDBS. So that is what, again, the last part, the excessive DBS patient with residual fluctuation, clear beta marker, they are the only subset of eligible patients, and the evidence is still maturing, although very promising, very sort of satisfying. And but we need to be sure, we need to acknowledge that it is still not completely, everything is known. The key practical takeaways. So those patients who already have a Percept system implanted, they can definitely be sort of, if they're doing mostly well with the continuous DBS, they can be seen if they have these fluctuations and on-time dyskinesias, they can be sort of subjected for the adaptive DBS to improve that further. And there is extra programming time both for the patient, for us, so that has to be sort of addressed. And the literature also. Nowadays, there are many other frequencies that are being targeted, especially the gamma frequency, which has a better potential than actually the beta power, and also the beta burst duration is also coming up to be a better sort of a biomarker compared to the power alone. And so take home message, that's what it's a latest step, very promising and a very good step, but it is still a step, and we need to know how good that step is going to be. And it is approved, safe, and feasible. That is definitely we know. How is it superior to continuous DBS? We just still have to be, read the literature for that. And the gradual selection adoption, because a lot of challenges are there. So even though they are compatible, still sometimes we may have to that invest that extra time and follow up for the adaptive DBS to sort of gain the full potential that it has. So I acknowledge my team at Animans and all the previous fellows. Thank you. I would be happy to answer any question.
Thank you, Vikram, for the overview of the adaptive DBS. Any questions?
Yes, sir.
What is the percent of aDBS going to the aDBS? Because FDA is approved and Indian approval is also there. What is among the available number of patients? How many percent of these continuous DBS will go to adaptive in terms of months or years or whatever?
I'm not sure that I'm not aware of that particular literature. But definitely, in all the studies, there are a subset of patients who are sort of choosing to continue with aDBS instead of cDBS, even though some of the parameters did not do well. In aDBS. So like for instance, some of them had a loss of, a couple of, maybe few 30 minutes or 1 hour loss of on time with troublesome, non-troublesome dyskinesias. Still, they chose adaptive DBS. So there are maybe certain parameters which you are not able to capture, which the patient is able to feel over the days or over that time, and thereby choosing for the adaptive DBS. And I think, most of them, they definitely, want to get better, in whatever way, like more, everyone wants more. That is the definite thing. But there are certain subset of patients who are also, again, switching back to continuous DBS, but that proportion may be around less than 20% as per the literature. I don't know about the real world scenarios.
Yeah, Guru Prasad.
Wonderful talk, Vikram. Why is it caution that you want to wait for some time before you go on to adaptive DBS? Why not initially?
So, I mean, it is like a fine tuning. Like, for instance, I mean, adaptive DBS is a fine tuning rather than sort of immediate. We need to know which is the, I mean, range where the patient is going to do, and in between in that range up and down, you are going to fine tune further so that it is very smooth. So that is the major, I mean, sort of thing that has been, and also maybe the trials took sort of those patients on current data available supports, like, I mean, patients who are doing relatively okay on continuous
What
DBS.
I've seen is if your patients get comfortable with the continuous DBS, they don't want to try anything else. So in my experience is because you have advantage of 4 groups, you can probably do a initial thing, set it, and then compare between adapt and continuous DBS. And if they're better with adapt DBS, then might as well use it. There's no much difference in terms of tolerability that way.
Yeah, I mean, mainly I think the literature sort of taken those patients, and we know which is the sort of pause amplitude and around which to sort of play around to improve further the outcome.
If I can just add that, I think with the Adapt DBS, one of the things is you're limited to only the middle 2 contacts. So with the continuous DBS or the conventional ones, you have 4 leads, and nothing replaces an ideally placed lead for sure. I would definitely side to the teams which are waiting for 3 to 6 months, because you want to wait for that initial stun effect to wear off. And it can also affect, the LFPs. People who have been on continuous DBS for a long time, their LFPs can also be suppressed. So when you turn the stimulation off, when you're testing, it doesn't come back up immediately compared to the newer cases. Like you said, it's absolutely about fine-tuning. And if someone who's pretty well doing, optimally on the CDBS, there's no need. But if we're struggling with a few parameters after 3 to 6 months, and it's a tedious process, but that's what fine-tuning is.
Yeah, I mean, the beta, I mean, that is also a valid point. Like initial 1 month, sometimes the beta peak may not be truly reflective of the patient's beta peak because of a lot of impedance and the healing process that is going on. I mean, but most of the centers do start a full, I mean, detailed programming, everything at 1 month. So I think, I mean.
So Vikram, just one question on the same beta peak.
Sure, yes.
Very nice talk. The same thing. Do you see that anatomical correlation, like when we do all these post-op softwares that are available, and your lowermost or the bottom 2 contacts may be in STN, and you may find the beta peak higher in another contact? Has this happened to you in your practice, that it's not matching the anatomical location of the lead where you see the beta peak?
Again, going back to the disclosures, I mean, I have limited sort of experience with that, but a couple of patients it did happen. Like, I mean, the beta peak is showing a particular part of contact, but the image guided sort of thing shows slightly a different contact.
See that, in our experience also,
So, I mean, the one thing is, like, I mean, everything's said and done, there is always a bit of difference. I mean, when the imaging is taken and fused, and there may be slight sort of a shift. But whatever studies, I mean, they have said that the beta peak is usually very, I mean, useful in locating the dorsolateral part of the STN. It usually doesn't, I mean, it is the highest to the, I mean, when it is, the contact is close to the dorsolateral. But that discrepancy, sort of slight discrepancies, definitely I have also observed.
To answer your question, beta peak is generally, as you said rightly, mostly in dorsolateral, but core STN. So central STN is where you basically see the beta peak. So that's why you go for center contacts as much as possible for recording. We started, I mean, none of these in this room may be Janardhan, but no one would have heard the term Activa PC plus S and Summit PC plus S. These were the predecessors of Percept PC. They came in 2012, 2013, and we ran a trial for Medtronic. We did 7 patients with this. And that's where we found this concept of single threshold and dual threshold. Because with single threshold, there was too much of ramping up and down, and ramping up and down cost a lot of battery. So that's why the dual threshold concept came in. And after the Percept PC came in US, we started putting it in. And as I think Dr. Guruprasad rightly said, we didn't wait too long, optimize the stimulation, and use adaptive if there are residual motor gains. that could be additionally gained if the patient is completely satisfied, there are no residual motor deficits, then we would not switch on the adaptive DBS. We'll just keep on continuous DBS. In India, though, if the patient pays for it, then he will want the adaptive stimulation. So that's why the conversion rate of adaptive stimulation in patients who have been implanted adaptive batteries will be 100%. And the two prerequisites is the lead should be rightly placed. The sandwich sensing also came in during our earlier finding that if you sense only from one electrode, there is too much of stimulation-induced artifact. But if you do a sandwich sensing, the stimulation-induced artifact goes away. And even during stimulation, the peaks, the oscillations can be detected by the sensing electrodes. So it's very good talk. He outlined perfectly everything. Adaptive DBS is only for the residual motor deficits that you cannot achieve by continuous DBS. And that's why the patient selection has to be perfect. The lead has to be perfect. So that's 70% you could achieve from continuous DBS. Remaining 15% you can achieve by adaptive DBS in addition to that 70%. But if any of those things, lead location is too lateral or too anterior, adaptive DBS is not going to work at all. It's leave apart correcting it. So it's a good step. The most important thing you need to understand that we are moving to closed loop stimulation. I think closed loop stimulation is the next step in our neuromodulation life. Open loop stimulation is coming to an end. Responsive neurostimulation in epilepsy or the spinal cord stimulation with gyroscope where the amplitude goes up and down, I forget the Medtronic's model name, and is adaptive DBS. If you need something, you deliver the stimulation. If you don't need it, you don't deliver the stimulation. I think that is a new step. That's why adaptive DBS is important. It's not important because it makes all the things better, but it is the first closed loop stimulation.
I think we'll thank you, Vikram. We'll close the session here. Thank you.
Good morning. Once again, a warm welcome to all the dignitaries on behalf of Manipal Hospitals Sarjapur Road. As Dr. Shivakumar said in his welcome note, thanks for sparing your time on a Sunday to attend our Manipal DBS Summit 2026. A special note of gratitude to all the dignitaries who has traveled from out of Bangalore, and a special thank you to Dr. Milind, who has come from East India, Kolkata, and Dr. Anurag Saxena, who has come from Dwaraka. Let us invoke God's blessings with a prayer song by Mrs. Rekha Rajesh.
पाहि पाहि गजानना पार्वती नंदन गजानना पाहि पाहि गजानना पार्वतीनन्दन गजानना मूषिकवाहन गजानना मोदकहस्ता गजानना मूषिकवाहन गजानना मोदकहस्ता गजानना चामरकर्णा गजानना विलम्बितसूत्रा गजानना पाहि पाहि गजानना पार्वतीनन्दन गजानना वामनरूपा गजानना महेश्वरपुत्रा गजानना वामनरूपा गजानना महेश्वरपुत्रा गजानना विघ्नविनाशक गजानना पादं नमस्ते गजानना पाहि पाहि गजानना पार्वतीनन्दन गजानना पार्वतीनन्दन गजानना पार्वतीनन्दन गजानना
To invoke the blessings of the Almighty, we will be having a lamp lighting ceremony now. To begin with, I request Mr. Deepak Venugopal, our Regional Chief Operating Officer, Manipal Hospitals, and Dr. Raghavendra to kindly come to the stage and light the lamp. I'd like to call Arnab sir, Mr. Arnab Mandal, Zonal Director, Dr. Shitija, Regional Head of Medical Services, and Dr. Pramod Pal to the stage. Thank you, sir. I'd like to call Dr. Suja, Cluster Director, Dr. Ravi Gopal Verma, Dr. Bhavna, Regional Head Marketing, Dr. Dwaraknath, and Dr. Milind Diogang.
I know, it's been a long time.
Thank you, sir. Thank you, ma'am. Now I'd like to invite Dr. Shivakumar, Dr. Ajay Hegde, Dr. Aditya Bharat, Hospital Director, and Dr. Archana to the stage, please. Thank you, sir. Thank you, doctor.
Very good morning to everybody. I think it's truly a humbling experience to be amongst some of the finest neuroscientists, neuromagicians, if I can use the word, who are all under one roof. So I think maybe a big round of applause to all of you who have come down from. Yes, the true magic actually happens in those OPD rooms, those video EEGs that go, those sleep studies that happen inside the theaters as well. I think we are all just so happy to see that different people from different institutions could come together on this Sunday morning, and I think Manipal is really proud that we can be a part of some of these activities. I wouldn't take too long between this and the clinical sessions, but something that keeps coming in our mind is that, guys, just 1 second. Just 1 second. So I think one thing that comes in our mind is that the balance sheets that we hold, there are lots of asset items in that, and I think some of us who operate those balance sheets, one thing that really gets missed out is the asset that the doctor team brings to the table. I mean, it is something which is very difficult to quantify, but the impact is large. So truly very, very proud that we are part of these teams where besides the MR, CTs and the buildings, which are the hardware, the real software is sitting here in this room right now. And we are so glad that we can be a part of that platform setting, which is the only job we do, where all of these minds come together and make it happen. The other part is all about this internal security that we try and create amongst people to share knowledge. I think it's been traditionally always a process where people are not wanting to share knowledge. I think these are platforms where if you're secure about what you do yourself, you want to talk more about it and kind of question and let people know that, look, this is what I do. Do you have any views on that? So I think this is the second template that we as Manipal create, that can you create secured clinical teams who are very happy with what they do and keep talking about it and also take feedbacks to make it better elsewhere. A link to that is the word which I've been hearing right now is this whole thing about distributed excellence. So I think the key should be that these knowledge gets shared and you have the same level of expertise which can happen all across our network hospitals. So whether you have something in Calcutta, and which is where Dr. Milan, when we were talking to him about 6-7 months back, requesting him to join us, we talked about all of you who are in Bangalore, and obviously, he knew everybody. Similarly, those who are in Bangalore could go to Calcutta. We have hospitals also in, Sahyadri, the west part of the country. So the distributed excellence is what I'm trying to say, that finally, whatever happens in this room here today goes back as a distributed effort to respective units of Manipal, outside Manipal, and the entire system, that people have an access to this premium care no matter where they stay. And I think that's the second objective which we want to create in our minds, that can we ensure that the same pedigree of delivery of care, the same standardization of care comes to all the places wherever people can access it. And I think that would be a true reflection of contribution back to the country. So with that, I will end. I think the last thing I want to just say is that please take care of your own selves. I think doctors are the most burnt out community in the systems. So do take your time off to cool those, the veins and arteries of yourself, and whatever we can do to make it easy. The whole effort at Manipal has been that we don't clog these arteries. We give you more work atmosphere where you enjoy your work. And please do take care of yourself. And thank you all for coming again. I'll stop now, but God bless and all the best.
Thank you, sir. I'd request one of the magicians, Dr. Raghavendra, to come to the stage and address the dignitaries.
Good morning, all. At the onset, I would like to thank all the colleagues and the neurologists and the neurosurgeons and clinicians who come on Sundays. I think the only day when they get to spend some time with the families. I am a part of this group, mostly from outside rather than inside, but Shiv Kumar and Dr. Ajay have been able to put together a very good program over the last 2 years to set up and evolve a movement disorder program in Sarjapur. As a clinical lead for Manipal across some of the hospitals along with this, we have been able to put together what I call as an integrated way of looking at neurosciences, particularly in Bangalore. I think we have 14 hospitals of Manipal in Bangalore, which would help us develop various subsets of specialities. For example, we have Yeshwanthpur, where we are developing epilepsy program with fellowships. And Millers Road, we are trying to develop stroke. So as with Sarjapur, we are trying to develop movement disorder. I think this sort of an extended platform across covering a wide population helps us develop very core subspecialties with time, attract more healthcare professionals and patients, and do help us deliver the finest quality of care. So we always look at West to give us the leads. I think the time has come with all the facilities, healthcare services and providers with so much of subspecialists, that we can be the lead rather than the followers. So I think I would congratulate Ajay and Shiv Kumar. I think they are one of the most active movement disorder programs in Bangalore now. They have done significant number of patients and they are taking lead. And we have substantially very active epilepsy group. So we do substantial number of epilepsy surgeries, SEG. So DBS is the next logical step for us in responsive neurostimulation, for us to handle some of our very difficult non-operative surgical cases. So I think congratulate Manipal to give a platform where different level of care can be provided to a large population at a program which is acceptable to different people. So this platform also gives a very good area where we can actually integrate various clinicians also at a very large scale. So I think at this I would stop and congratulate the hospital chain and also all the clinicians for this great conference. And again, congratulate Shiv Kumar and Ajay for pushing such a program so aggressively in last 2 years. Thank you.
Thank you, sir. We'll continue with the summit. Next is aDBS workflow by Dr. Janardhan Vaidyanathan, Principal Specialist, Training and Education, Neuromodulation, Eurasia, Medtronics, India. The chairpersons for this session would be Dr. Sanjeev CC, Dr. Rakshit K, Dr. Shabari Girishan KV. Request Dr. Rajesh to come to the stage as a chairperson for this.
Okay. But I could get some thoughts started. Yeah. So, good morning. I must make a few confessions before I begin. So, first and foremost, I'm not a medical professional. I'm an engineer with a PhD, a biomedical engineer with a PhD in industrial engineering. So, I see things a bit differently, just networks perhaps, and maybe oscillators to begin with. And then frequencies might be identifiable in certain conditions, and we could perhaps use them as tags in order to identify either disease states, could be traits, symptoms, and then use that feedback in order to control the stimulation dosage. So, two modes were discussed in the previous lecture. One of them is the single threshold mode, and the other one is the dual threshold mode. As I would wait for the system to be started up, I would just like us to think about a person trying to balance on a tight rope. So I'm sure we've all seen street acrobats who very wonderfully try and balance. So that is an example, an analogy of a single threshold. So that particular kind of a system has only two states. It's either on one side or the other, and it has to keep fluttering constantly. So it's a system which adapts quickly. So it's a fast adapting system, the single threshold, because like the person who's balancing on a tight rope, there's only one single threshold that's available. I'm sure most of you in the audience do drive cars. So I do not. I ride a bicycle, but then I'm sure for guys who drive cars, you know what a lane assist is, especially these days when we have aDBS, Advanced Driver Assist System. So aDBS has different levels, and you could think of lane assist as a dual threshold. So dual threshold has three possible states. You can either be above the threshold, you can either be below the threshold, or you can be in between thresholds. So it's essentially like a traffic light. So you have red, orange, and you have green. So there are three possibilities with a dual threshold. So like I know you really can't drive or steer a car so rapidly. So that is a slow kind of a responsive system. So you could perhaps imagine that a dual threshold essentially has three possible outcomes, three probabilities. It either is above, below, or in between. That's for the dual threshold. The single threshold, like a tightrope walk, is only either this way or that way. So it's actually two possibilities, like a switch. It's either on or off. So yeah, thank you for bringing life to the presentation. So very grateful. My task today is to actually share some aspects of the workflow, and I would like to think of the brain as I could think of the brain as a dynamic oscillator, and that dynamic oscillator essentially may have an oscillopathy, and that oscillopathy essentially is a network disorder that we're trying to address. And hence we can use a device like a brain radio, listen to the oscillations and respond to them. So we can either try to track maybe symptoms, we can try and understand states. Is the brain awake? Is the brain asleep? Is currently our medications being effective or not? So we could understand disease states, some symptom traits by using those oscillations as a biomarker. It's very different from an evoke potential, which you all are so very well aware of. But there also potentially might be a biomarker, might be a evoked potential of interest that might come up in the future. It's the ERNA, the evoked resonant neural activity, which might come up in the future for DBS. Like how we have ECAPs for spinal cord stimulators, evoked compound action potentials. This is a true biomarker. So I can just think of DBS trying to reduce the noise in the network and making the message heard. So we're trying to reduce the noise in the network and making the message heard. And that's how we're trying to restore the dynamics of the network. And we could say today that local field potentials are essentially an electrophysiological biomarker, and we can detect it in several patients in the off medication state and also in the on medication state. We can detect them in at least one hemisphere. And one hemisphere is enough for us to drive adaptation on both hemispheres. So the ability to do adaptive DBS, we can even drive from one single hemisphere. We can drive aDBS in single or dual threshold mode with even one side sensing. Because maybe on the other side, we may not have impedances in the normal range. Maybe we are not selecting a certain configuration which is sense-stim compatible. So for those reasons, perhaps we may not be able to use the other side, or maybe the other side we do not have a biomarker that is detectable. So I would think of beta as the bad boy in Parkinson's disease, just for me to understand things at a very foundational level. And it essentially is that in Parkinson's disease, the beta suppression during movement initiation is delayed, reduced, or it's incomplete. And because of that reason, beta or alpha beta now, so beta essentially becomes blocking, antikinetic, or it becomes the band that is trying to oppose the movement. And we're trying to detect this beta using the brain sense channels. So beta is the bad boy. We've now rechristened the same beta as the alpha beta. Alpha beta essentially because we have 8 to 30 hertz. The classification essentially has been adopted from EEG. Alpha, beta, gamma, first 3 letters of the Greek alphabet system. Even alphabet comes from alpha, beta, both together. So, and of course, they all are arranged in increasing order of their frequency components, but then when delta and theta were discovered, we did not have alphabets before alpha, so we had to resort to other alphabets in order to name those lower frequency bands. So alpha, beta, we're just adopting the convention that's available. There's nothing specific to the LFP with the DBS. There's a new feature on the device, it's called the electrode identifier. And essentially, it's about the ability to detect signals either using a bipolar differential recording or a monopolar referential recording. So 2 ways that we can actually detect LFP signals. We can detect using a bipolar differential recording. The differential recording will give us a relative value. The referential recording will give us an absolute value. So there is the difference. You can either get the relative value or the absolute value. The absolute value actually gives us some insight about the source, the proximity to the source. If you're close to the source, for me it's imagining a candle flame. Imagine a candle flame and there are four electrodes. Imagine a candle flame. If I'm close to the candle flame, an electrode will see that the brightest, and my ability to put off that candle flame effortlessly will be with the electrode that is the most closest to that particular candle flame. So delivery of therapy is done with less energy if you're close to the source. And that is essentially the idea of having something with regards to LFP, source localization, and the monopolar referential recording, which gives us the absolute value with the dot scores, is a feature that's available on the device. If you look at the workflow, we could perhaps use the localization tool here to identify the best the best contact. Of course, this will not replace the review and the neurological assessment. It will just give us guidance. It will give us proximity to the source that is the generator of the of the biomarker signal, and essentially we're trying to track the undesirable component of that particular biomarker. So you could have a gamma, you could have a beta. Gamma is the high frequency, beta is the low frequency. Again, more classifications are evolving in the beta. You can have a low beta or a high beta. Even gamma, you can have a low gamma or a high gamma. Now, the understanding with gamma is that the gamma can be entrained in the network. So if you're stimulating at 130 hertz, for example, or 125 hertz for sensing, roughly half of that frequency gets entrained in the network, and that is what we pick up during sensing. So it could either mean that the patient is doing well in terms of motor symptoms, or it could mean the person may have dyskinesias. We'll really have to look at it. But gamma could be a biomarker of interest in that case. In Japan, we have an inverse threshold mode. Only two modes were discussed, the single and the dual. In Japan, we have the inverse threshold, which is approved there. Nowhere else in the world it's approved. So inverse threshold essentially will track gamma. And as gamma increases, the stimulation will decrease, because it's an inverse relationship. So we could use tools like the electrode identifier, go with levels and then segments, and then identify proximity to the source like a candle flame, and then activate those electrodes. Dot scores are provided. Dot scores essentially will give us the top, the top 20%, that's 3 dots. 40 to 80% are the dual dot scores, and the last 40% are the single dot scores. So they'll give us dot scores in terms of telling us how high the beta power peak is. Now that value there has a unit, it's microvolt peak, and that's a value that we'll have to check about the ability for us to be tracking signals. Anything above 1.2 microvolt peak is reliably trackable. Anything less than that, we may not be able to track. You may try to push the boundary, go up to 1 microvolt peak in case you have feeble recordings, but anything less than that, we may not be able to track and adapt to. 3 steps in terms of activating aDBS. We really need a timeline in order to be able to calculate the thresholds. In case it's a single threshold, we can calculate only one number. If it's dual threshold, there are 2 numbers. Then we essentially will determine the stimulation limits, the maximum, the minimum, and the paused amplitude, and then we can activate the therapy. So when we look at how to leverage the current workflow, so I know there are a lot of discussions, this is still evolving. Essentially, sensing could be set up initially. It's passive sensing. So passive sensing can be set up initially, right in the beginning. At least we can have a frequency of interest that is qualified, a frequency of interest that is validated. If we begin early on, even during the initial phase, we at least have the frequency of interest identified. And then, of course, eventually, if we are not, satisfied with that particular frequency of interest, we could adjust the frequency of interest based on the events that are captured outside the clinic. So sensing offers a powerful set of tools that can be used in the clinic or outside the clinic. In the clinic, essentially, we can do a survey, streaming. Outside the clinic, we have timeline and events. Each of these are for answering different questions. Survey will try and answer which electrodes could be the most optimal for us. Streaming is trying to answer the question, how much dosage is appropriate, stimulation dosage is appropriate, because we want to see a dose-dependent response. We want to see stimulation increasing and the LFP power decreasing, or when we put the stimulation down to 0, we want to see the LFP rebound. So when it rebounds, we know we have a signal, a frequency of interest which is qualified. So that is the use of streaming. Now outside the clinic, the timeline is such a powerful tool because it allows us to understand what's happening with regards to the washing in, washing out of medications. How is the patient actually doing outside the clinic? Does that timeline show sleep? Because circadian rhythms essentially will show beta power reducing. So all this will allow us to really qualify and validate that frequency of interest. The patient can capture events. We can configure up to 4 events, but patients, we can assign at least 2 or 3 events, one neutral event, and maybe one where the patient is not good motor symptom wise, and another one where the patient is doing well motor symptom wise. So, and then we can identify if there are other frequencies which are important for us. So those are the essential ingredients for us to really start off adaptive. And then of course later we can determine the thresholds. And Dr. Hola was mentioning about the LFP power value. LFP power value is an arbitrary unit. It's an arbitrary unit. It's not having a unit like microvolt peak. So we cannot use it to compare between hemispheres. We can only use it to compare on that hemisphere itself. We can't use it as a number to compare between patients or between hemispheres. It's an arbitrary unit. So in terms of the journey from cDBS to aDBS, we want to embed adaptability in the stimulation dosage. We can nest it in the normal routine workflow. It's a personal preference as to when we would want to start it. We know PD is a disease that evolves with time. So if a patient is doing well on cDBS, maybe conservatively thinking, perhaps maybe you can think of aDBS reserved for a later time, or you may want to begin early in case we want to achieve certain objectives. Specific objectives for that patient, maybe address dyskinesias or address some other issues which might not be achievable with optimized cDBS. So those options remain. And yeah, we can provide groups. In the beginning, we actually have the amplitude limits which are quite tight, and later on as the disease progresses, you may want to relax those amplitude limits. So ideally, we do not expect the patient to be immediately better, but at least we expect the person not to be worse off from cDBS, because that essentially is what the ADAPT PD trial showed us. So we essentially want to have the stimulation adjust to the pathological variations, but preserve the physiological variations that are natural to the networks. And that essentially is the beauty of adaptability. And there are tools to select the electrode, as to which electrode we would want to use. There are tools for optimization. There are tools for maximization of the therapy. So tools for selection are survey and the electrode identifier, what we discussed a moment ago, the bipolar differential recording or the monopolar referential recording, and of course identifying the frequency of interest. Streaming is a powerful feature that can be used in the clinic. And to maximize the therapy, we have aDBS modes, the dual threshold mode and the single threshold mode. So the dual threshold mode essentially is like the lane assist with the ADAS system cars, because you might have an aggressor that is trying to break out of that particular limit that is set. We want to suppress that aggressor. Sometimes we may have a signal that needs to be recovered because that signal is going down below the lower threshold. We may need to recover that signal. So we might have an aggressor, or we might need to do the work of recovering. And that is essentially what the adaptive therapy does in patients. So layering it into the workflow is possible when we select patients who would have stable medications, and the only thing that needs titration is adjusting the stimulation. Some patients might be using a patient programmer. So that additionally gives us the opportunity to set it up in a specific adaptive mode, and the patient no longer needs to change the dosage depending on certain times of the day or certain tasks that they need to undertake. If the patient and the physician believe that there is room for improvement, there are motor fluctuations, some symptom breakthroughs, or potential side effects, there's a possibility that we could try the adaptive modes in here. So I think there are two key things. First is the identification and the selection of the patient, which is a clinical decision. Then we have the preparation of the patient, which is the most important foundation for us in order to have the activation and optimization. Ideally, activation and optimization should not take more than 20 minutes or so, or 30 minutes. And the beauty of adaptive is that patient can be in any state. So the patient can come to your clinic for aDBS activation or aDBS optimization, even though they're in an off state, on state, or in between. So they need not be in any certain state because we've already taken those numbers from the timeline historically. Now, choosing the appropriate patient involves so the appropriate patient is a patient where we think there might be still room for improvement, someone who is willing to try a new mode, and of course there is presence of a suitable biomarker that we can adapt our therapy to. And biomarker validation is also critical. So we assess that sleep circadian rhythms are reflected in the timeline. It's absolutely essential. Drugs washing in, washing out, because we want to adapt to something meaningful, something that reflects the patient's clinical state. Because setting up the brain radio is easy. It is like tuning a radio, because the radio will get tuned to any frequency between 8 to 30. But which radio station do I want to listen to? Do I want to listen to the news, music, classical, sports? So we essentially want to tune the radio to that specific biomarker, which is meaningful for the patient. So ideally, the patients chosen for aDBS, as per the ADAPT PD trial, they were stable for 30 days with medication and stimulation. And they were not in the medication adjustment phase. They had some task-specific challenges which were not addressable with cDBS, so they could be potential candidates. And it's only once the patient is stable with cDBS, because we don't want to have too many variables, and then we do not know which one really is benefiting the patient. There are different modes, the dual and the single, what we discussed. Of course, it's not a salvage therapy. It's not to fix cDBS either. So those are our own expectations that we're trying to set. And which patients are ready for aDBS? The ones in whom fluctuations are noticeable on the timeline and it's validated with a circadian rhythm. They're stable on cDBS. They're not for salvage patients. We at least have 2 weeks of timeline data representative of the routine daily activities, because sometimes when we measure on the timeline, we can get artifacts. Now those artifacts can really obscure the data that we want to capture in terms of threshold numbers from the timeline, and hence it's nice to have some redundant timeline days with us. Yes, we just need 3 days. We just need 3 consistent days, not consecutive, consistent days. We leave out the odd days, days on which maybe I've had a vacation, I had some stressful events, maybe at office or at work or wherever. So we leave out those odd days. We want to adapt to normal days. And hence, getting that 2 weeks cushion really allows us to filter the data and make sure that we have some redundancy in terms of trying to select those numbers more precisely. Whom not to choose, perhaps, patients who are really happy with cDBS, they do not want to change. And of course, signals where we do not have a value more than 1.2 microvolt peak, because we cannot reliably track those numbers, track the signal. And in patients in whom sensing was never started, someone who lives far away may have logistic challenges. And in patients who are not compatible with sense-stim configurations, because the sandwich mode, which was mentioned by Professor Degaonkar in the previous session. So if we are not in that sandwich mode, we're not able to have a brain sense feature activated. But of course, if you have the possibility to activate it on one side, you can still drive adaptive on both sides. So we can use contralateral. we do not need sensing to be activated on both hemispheres. You can still drive adaptive with sensing activated on one hemisphere only. You can drive both hemispheres because medications wash in and wash out similarly on both sides. The preparation is the key, and the preparation time the preparation is based on the timeline, gathering the timeline, and we see some fluctuations during the daytime when the patient is awake. We want to ignore the outliers. That's very critical, so those numbers are not confounded. And we do not want to change the stimulation electrodes also during this preparation time because we want patients to be stable for at least 30 days. We want to avoid patients who do not have a signal or because even when they withhold medications, because then we are not able to really measure a biomarker of interest. So maybe we can only go with one side if you're able to detect the signal on one side alone. ECG is another confound, and what I know from engineering is that the most strongest part of the ECG is the QRS complex, and that QRS complex frequency is overlapping with the alpha beta frequency. That is 10 to 50 hertz. The QRS frequency component is 10 to 50 hertz. What we measure for alpha beta is 8 to 30. So sometimes we might also pick up artifacts from the ECG. And there's a simple maneuver that you can use in the clinic. It's raising the arms or maybe drawing in air and holding the breath in order to check if the LFP power changes. If it changes, then it is an ECG artifact which is inducing it, because the QRS complex has the same frequency component, roughly 10 to 50 hertz, similar to what we have for the alpha beta 8 to 30. So those are things that help us in the preparation phase, because then we know that our signal is truly measured from the brain. We're not responding to something from the heart. And in terms of activating patients, we really don't have a preference, but the best practice is when activating when the patient is nearing the off state. So then you can check the minimum stimulation limit there, which we need to set. And of course, once the patient takes the medication, we can check what happens with the maximum stimulation amplitude. So then we have checked both those limits that need to be assigned for as part of aDBS. And movement artifacts is something that we discussed. Streaming is a powerful feature. I touched upon this, where we see the variability, we see the peaks here, but we also see a dose-dependent response in terms of the decrease of the LFP power when we increase the stimulation dosage. It is time-locked. And another wonderful feature of streaming is that when you switch off the stimulation, you'll see the LFP power come back. That is rebound. So that rebound is a powerful tool for us in order to validate the FOI in the clinic. Two things to validate, either streaming or the timeline, both. And that is really qualifying the FOI. So once the timeline is built, we see the fluctuations, we capture the sleep. And we also ask the patient about their sleeping habits. Sometimes we see the afternoon siestas also clocked in on the timeline. So we really are very sure now that the timeline is tracking the patient's clinical state. And it's a meaningful signal for us to really adapt to. And the timeline has to be representative. It has to be reactive to stimulation dosage. It has to rebound. So those features have to be checked. Only then can we qualify, validate the timeline and the frequency of interest. Artifact confounds, just showing you an example. Here you see a flat timeline. But you can see that one outlier there. Always begin with the y-axis. I'm actually stepping away from the mic, I apologize. But always check the y-axis, check the range of the y-axis. And if the range of the y-axis is an absurd number, like here you see that number is very huge, I can't even count it, comprehend it. So that is definitely an artifact there, which is flattening our timeline. Here you also see a flat line. You have artifacts in each of these, because those numbers are really huge. You can see that artifact there. Some artifacts are there, but it's really not flattening the timeline here. We can still remove some numbers of interest from the timeline, and hence it is nice to build up at least 2 weeks of data so that we can take 3 normal representative days from here. So the key takeaways are essentially building a frequency of interest, and that must respond to stimulation or medication. In case you see multiple peaks, it's possible that you see multiple peaks in the beta. So select a peak that is responsive to medication or stimulation depending on which threshold mode is selected. If it's perhaps a single threshold mode and you want more responsiveness to stimulation, you may want to select the high beta. In case you want to really respond to state changes, then and a slower way of adaptation, you could select the low beta, which is more medication responsive. So those also could be built into the system with regards to how we want to adapt. And I think all settings cannot be done in one sitting. So we would need frequent, I would not say frequent, but some visits in the beginning to really set up. I think we covered this. The LFP power units have already been discussed. It's an arbitrary value. It's that area under the curve which we show up as those LFP power units. So those are arbitrary units. They do not have any. They do not have a. It's not like kilometer, millimeter. It's not a standard unit. It's an arbitrary unit. So that's something that we have coined. In terms of setting up, it's again easy. Finding out thresholds, setting up the min and max limits, and then activate aDBS therapy. So here we have the timeline analysis tool using the scrubber. Scrubbing tool, you can find out those values, the LFP power values. Ignore the sleep hours. Only look at the values that we have in terms of the high and lows during awake hours, and you can use those as thresholds. Of course, you have to calculate the threshold, 75% and 25% of that when we start working on our thresholds. So exclude sleeping hours, and then in the awake hours, look at what is max, look at what is min. Each line there is a 10-minute average, and then we essentially want some of those to be above the upper threshold and some of them to be below the lower threshold. We always want sleep to be below the lower threshold. We always want sleep to be below the lower threshold because we want the stimulator to turn down during sleep, and we want sleep to be below the lower threshold. So like those, it's an imaginary line. It's an imaginary line that we can draw, or you can use a good old transparency. I don't know if transparencies are available, but I would draw a simple line and superimpose it on the tablet for it to be an imaginary line. So those are the things in terms of finding out the three consistent days where those numbers are holding. And then we can set up the thresholds. So the calculations are also simple. Identifying the max and the min values, the paused amplitude is important because when the device is recharging, if there's a rechargeable device, it will be set to the paused amplitude. The max and the min are tested in the clinic acutely to make sure that the minimum is enough for the patient to still be mobile at night in case they walk, in case they need to walk and they need to move. Then that minimum at night is enough, and that maximum is also not going to really cause them any side effects. In the beginning, you can give a very tight range here. You can give plus or minus 0.1 or plus or minus 0.2, or sometimes you can give plus 0.2 and minus 0.1 also. It could be symmetric or asymmetric, whichever way. And then, of course, seeing how well the system adapts. So for dual threshold in the clinic, we really can't see anything happening with dual threshold in the clinic. With the single threshold, we can assess in the moment. We can check on the duty cycle. We can check on the duty cycle, and the duty cycle will tell us about how much we are providing additional stimulation. So as my colleague Bala taught me, it's about like for example, a single threshold mode, we're trying to take more juice out of the neurostimulator. We're trying to draw more stimulation dosage from the neurostimulator without inducing side effects, without overstimulating. So we're trying to draw more juice. So when the patient is off medication, we would want to draw more juice, which means the stimulation will hover around maximum amplitude more than it would at minimum amplitude when the patient is off medication. When the patient is on medication, we don't need as much stimulation dosage, so the adaptive stimulation will hover around the minimum stimulation amplitude. So those are aspects of the duty cycle, and it allows us to validate in the moment the same thing that I was mentioning a moment ago. So you can see that the time the stimulation is spending there and there. So that is max amplitude, that is min amplitude, it is almost 50%. When the patient is on medication, we want the device to spend more time at the min amplitude, minimum amplitude. So we are not providing that additional dosage. You can see the additional dosage is that area under the curve. You can see that area under the curve. That is the additional dosage that we are providing. When the patient is off medication, we need a duty cycle more than 50%. So we are providing more area under the curve. So you can see the example here with that LED. As we increase the duty cycle, you can see the brightness increasing. And that essentially tells us that we are delivering more stimulation dosage as the duty cycle increases. So this allows us to check in the moment, and at a glance, if you were to compare both, I would think of shock absorbers. And I think there's no dearth of examples around us. So if you actually look around, there could be motorcycles or even bicycles with a shock absorber on both sides, right? So that's like a dual shock absorber. All what we're doing is we're trying to dampen the oscillations. We're trying to dampen the oscillations of the system, and we're able to have a dual threshold, and it takes 2.5 minutes to reach to maximum, 5 minutes to ramp down. That's the default. Adaptation happens slowly. So we adapt to state changes. We adapt to state changes. Whereas a single threshold, we adapt to events, which may be unpredictable. One more thing about the single threshold is that both hemispheres will fire together. So if one hemisphere fires, the other one will also fire. And I think it's such a powerful thing which is built into adaptation, because then we are getting a boost on both hemispheres simultaneously with a single threshold. With a dual threshold, however, it is individual. So one side fires based on its own individual set thresholds. The other side will also fire individually on its own thresholds. They have no interdependence because it's a slow mode. It is changing, it is based on state changes, whereas the single has to adapt faster. Single has to adapt faster. One changes, the other one will also change. That's the power of the single threshold, because both fire together, and I find it so appealing, because we get a boost, or we can decrease both sides simultaneously. And I think that simultaneous, synchronized increase or decrease is a powerful tool that's available in the single threshold mode, and it's fast. We can also do contralateral sensing, something that we've been discussing. So if you're not able to detect signals on one hemisphere, you can still drive adaptation on both hemispheres if you're able to detect signal from at least one hemisphere, because medications will wash in, wash out. Similarly, you can use both single and dual threshold with contralateral sensing, right? And of course, there will be some coherence between both STNs. Medications will wash in, wash out at the same time. The amplitude parameters will be different for the two hemispheres, but they will get triggered by the same LFP biomarker. So that's contralateral sensing. In case you're wanting to change from one mode to the other, the device will clear all the captured thresholds of the previous mode. So maybe it's better for us to set up a new group or even document the numbers in case we want to roll back to another old threshold. mode. So it's possible. The steps are very similar in order to set up. The optimization phase, so that was preparation and activation. This is optimization. So optimization essentially involves two dimensions. What did the patient report and what does the brain sense data tell us? Two things that we're trying to look into. So like, is the stimulation adapting well, or is the stimulation not adapting well? And if the stimulation is not adapting well, what is it doing? Is it railing high or is it railing low? Now, railing means it is stuck. It is stuck at high or it is stuck at low. So if it is stuck at high, what is it not doing? If it is stuck at high, it is not crossing the lower threshold as often, which means we have to increase the lower threshold. If we increase the lower threshold, the LFP signal will cross the lower threshold and then it will not be stuck at max. If it is stuck at min, it is railing low. If it is railing low, what is it not doing? It is not crossing the maximum, the upper threshold as often. So we will lower the upper threshold. So if the stimulation is not adapting well, we will change the thresholds. If the person reports overstimulation or understimulation, we could then adjust the stimulation parameters like the min or the max, or even the paused amplitude, depending on that specific case. So we have a quadrant tool, and that essentially is describing the railing high, the railing low, or stuck at max or stuck at min. So those tools are available, and this is a workflow that we have discussed. It's just a pictorial depiction. So optimization, we essentially look for whether the stimulator is adapting or not. Then we change thresholds. If the stim is adapting well and the patient reports over or under stimulation, then we'll change those limits. And we eventually want the patient to be better, not worse. So of course, we'll have to titrate a bit sometimes the stimulation dosage, depending on the patient. Reading of the timeline is very critical because the sampling of single threshold is 20 hertz. The sampling of dwell is 5 hertz, whereas what average we see on the timeline is 10 minutes. So we'll have to really interpret all this in that temporal sense of the term, because one is 10 minutes, the other one sampling is 5 minutes, and another one sampling is 20 seconds. So we really have to interpret, and it's just building our visualization of how the graph must look like in a certain context. So optimization, again, is mainly two things, either changing the threshold or changing the stimulation min or max. So it is either stuck at max, railing high, stuck at min, railing low, and then we change the thresholds. If the patient is doing well, then we do not change any of the stimulation settings. So that is railing high and railing low. And we have the quadrant tools which are available, and we have all those resources as PDFs, which my colleagues will share with you. So all that is available for your ready reference, and they're very, very simple. So during optimization, we use the quadrant tool. We ask the patient how they're feeling, and then we check if the timeline is adapting or not, and then adjust the thresholds if necessary. The timeline with aDBS will look different than what it looked with passive sensing. So it's very important to interpret it in that context, actually. So the overview of aDBS modes, this is something that we began discussing before my computer got connected. So essentially, we have single threshold, which has 2 responses, a dual threshold, which has 3 responses. Single threshold is like a switch. It is on or off. Dual threshold is like a traffic light. You have red, green, and orange. 3 possibilities. But for a switch, you have on and off only. So two possibilities. Single threshold, single threshold essentially is, like a quick on-off switch, so it'll either be at max or min. It's like a coin flipping, 50% chance of one or the other. It's a probability, so it crosses the threshold, it'll either go to max or min. It will not be in between. It will not be in between. Whereas the dual threshold mode can be in between because there are three responses: increase, decrease, or hold, like the lane assist, of the ADAS cars, right? You can have increase, decrease, or hold, and that is also the beauty of the sensing modes that we have. And maybe dual is better for state tracking, where single is more relevant to bursts or events. So one is event driven, the other one is state driven. One may be slower, the other one may be faster. And for me, it's like a spring, you know, you dampen. It's like I'm thinking of how I'm riding, how is my ride quality. So sometimes I might be bobbing. If the suspension is set up very firm, very softly, then I'm just bobbing, right? If my suspension is set up very hard, I'm bottoming out. That really is the railing phenomena that we discussed. We want the system to be critically damped. So the levers that we have are the modes, single or dual. We can have the amplitude settings. We can change the thresholds and also use the quadrant tool. We also have the possibility to use contralateral sensing. So the tools, something that we've discussed, where to stimulate, how much to stimulate using streaming, the when is the timeline and events, and based on that we can drive the aDBS. So we have a full comprehensive suite of features. This is just a point of view. As I ride a bicycle, I'm just showing you one with a single suspension and another one with a dual suspension. Both essentially work on the same principle. We're trying to dampen the oscillation in the network, and we're able to dampen it either quickly using a single threshold or doing it slowly with a dual threshold. So essentially, if we have something which is spiky or cyclical is something that we have to decide based on the timeline review. If it's something spiky, maybe it's more amenable to a single threshold. If it's cyclical, then it may be more amenable to a dual threshold. Something that is burst driven could be single thresholds because it's driven by beta bursts. If it is driven by beta trends, it could be state driven, like the dual threshold. So that is where the thought process can sit in terms of the choice, making a choice as to which one could be more appropriate for a given patient. Of course, at the moment, we think both modes are good because both give us additional on-time without dyskinesia based on the ADAPT PD. It might vary in a specific patient case. The single threshold essentially will detect and react. The dual threshold will monitor and stabilize. So the detection and react essentially will involve delivery of a booster without overstimulation. So we are boosting up the stimulation as and when required without overstimulation. Whereas for the dual threshold, we try to keep the patient in the stable on state in between the thresholds. So that is where the optimal state of the patient is. And these are the two modes. It's just a picture. One showing you either two states, either max or min. And this one, you have adaptation happening in between also, and it's adaptation happening in order of minutes. The other one, adaptation happening in order of seconds. There are a lot of learning resources available, and we remain at your service in case you want to get in touch with any of us from the team. I'm so grateful for your time and attention. These are just summaries of the same aspects, and then just a pictorial depiction of how I visualize it. So you can think of a roadside acrobat. That's a single threshold mode requiring quick adaptation, whereas the other one essentially is the dual threshold mode with like the lane assist. I'm so grateful for the time. Thank you so much.
Excellent talk, Dr. Janardhan. I would like to ask one single question. You said beta activity can also be masked by the artifacts. Suppose in the case of clinically patients having dyskinesias, they can alter the beta activity. How do you come over that phenomenon? How do you want to correct it?
So I can think of dyskinesia influencing or inducing movement related artifact.
Yeah.
So they may, so if our objective is to capture this survey, and if we detect an artifact when we have dyskinesias observed in a patient, perhaps I would want to wait for another moment in time and see, because with dyskinesia, with artifact, our signals will be contaminated. We will not be able to make any conclusions based on that observation, but we can have a timeline. If we build a timeline, and when the patient has dyskinesias, because it's a 10-minute average, it may not be so much influenced with movement artifact, because that movement artifact might be a stray event happening over a period of 10 minutes or a few more minutes. But at least for the other part of the on time, if I'm able to see a low beta, then I'm knowing that there is drug responsiveness with regards to the beta getting suppressed on the timeline. I might not be able to use the streaming tool in the clinic. I might not be able to use the survey tool in the clinic because they're acutely sampling. But if you're using the timeline tool outside the clinic and patient has dyskinesias, yes, we are recording the LFP power in 10-minute averages. So maybe we are able to capture some beta reduction. Maybe 1 or 2 10-minute observations will still be outliers because they are inflated by that movement artifact. So we might have to ignore those numbers. But otherwise, we would expect the LFP to be reduced. One more wonderful point that you bring up in my thoughts is split sensing. I forgot to mention split sensing. So you can actually track one frequency on one hemisphere and you can track another frequency on another hemisphere. So if you feel that low frequency is important on one and high frequency might be important on another hemisphere, you can tune the brain radio differently on both hemispheres to track low and high. So maybe when patient has dyskinesias, you're able to pick up gamma on the other hemisphere, even though this, or something of this nature, like using an averaging tool in order to suppress the movement artifact, one, using the timeline because it has a built-in averager, and second is also split sensing, set up different frequencies on different hemispheres. So the low frequency must get suppressed, and maybe if there is dyskinesia, we expect perhaps the gamma band to increase, but there is understanding now that the gamma band might be an entrained biomarker. So we may see that biomarker increase only with stimulation at half the stimulation frequency and may not be with regards to dyskinesias induced by medication. So the gamma induced by medication may or may not be observable in all patients. The gamma can be induced by stimulation, and that stimulation, the gamma that we pick up will be half of the stimulation frequency. It's an entrained biomarker. It's entrained by that frequency. It is either 1:1 or 1:2. So it might be at the same frequency or half the stimulation frequency. And that may tell us that the patient is doing well or may have dyskinesias. So better to use an averaging tool and maybe outside the clinic feature.
Thank you. Any questions from the audience?
Good to see you after a long time. I have a patient with dystonia doing very well on standard programming. But he is a IIT Kharagpur engineer and we had put in Percept PC in it, Percept RC in it. So he is asking me, can you turn on the adaptive stimulation? Now the question is, if it is dystonia, do I look at gamma frequencies for double thresholding?
Adaptation is not possible with any other indication. I apologize. I'm lost in thoughts. So adaptation is not possible for any other indication other than Parkinson's disease at this point in time, because in the beginning when we set up the device on the programmer, we select an indication. Like for example, cycling is only possible when we select epilepsy. Adaptive is only possible when we set up Parkinson's disease as the indication. So adaptive is currently not available for dystonia. Passive sensing is available, and in the LFP compendium, we have certain frequencies that correspond to tonic, phasic, and all those dystonia components, and we can show you the compendium reference. But I would not be able to recollect the exact numbers at this point in time.
Guru Prasad.
So with regard to GPI stimulation for Parkinson's, so what difference do you find? Do you use it for GPI stimulation for PD? And if so, what difference do you find from the STN stimulation for PD?
So GPI, so in the ADAPT PD trial, both STN and GPI patients were included. GPI would also have a similar response as we see with STN in terms of adaptation or being able to record the sensing signals. The circadian rhythms may not very well be represented in the GPI as in the STN, so you may not see that sense of calm during the sleep hours in the GPI. The GPI numbers might be slightly larger because of the nucleus size. I think I will also refer this to Bala, please, if Bala is around, because I know he also has experience on GPI. So Bala, please.
So only difference I saw was when you do the survey, the frequency of interest which we see, the power is very larger in GPI. It is very easier to find the power which is more than 1.2 microvolt peak. So that is a major difference which practically we have seen between STN and GPI.
But if you don't see too much of fluctuations on the GPI when compared to the STN, and also I think when we are doing the intraoperative stimulation, Vikram will say, the GPI actually, the intraoperative stimulation doesn't change as fast as STN, right? The tremor suppression, all that thing. There's a lag in the GPI compared to the STN.
That is with respect to the motor benefit.
Yeah, motor benefits, yes.
But I mean, the beta peak and the power is sort of, as I told, I mean, it's reflective in both GPI and STN. Only the values are slightly higher.
STNs may be like 3 or so, or 1.2, 1.5, 2, but the GPI might be of the order of 6 or 7 or 8 sometimes. So that's one. And yeah, that's the latency of response, I think, with regards to seconds, minutes, hours, days, weeks, or months, with regards to symptoms responding.
Yeah, I actually wanted to ask about the same thing about GPI. So we've been using quite a bit of GPI. So we see a good amount of LFP recording, and I mean, we are not able to compare because our experience is much more GPI than things. So, but I don't think there's any difference. Even ADAPT PD trial also showed that there's no difference between, because there are equal number of STNs and GPI DBS taken in the trial. So that way, evidence also speaks for that. But you were mentioning about the timeline, about the sleep assessment. I was curious to know what's the difference. The other thing is when you say burst, difference between single threshold and dual threshold, when it implies, the clinical implications is, do you say that when there is a sudden offs or sudden severe offs, that's the type of patients who will respond to single threshold? Or an example of early morning dystonia, that's the one who will respond to single threshold. So how do you decide which patients will benefit with single threshold or dual threshold? You have a particular set of patients who will do well with single threshold, or certain patients will do well dual threshold?
So with GPI...
either STN or GPI.
Yeah. So, but the first part of the question with regards to GPI, sleep, and how different it is from STN, I don't know if it's the same experience for Bala too, because the GPIs generally may not show calmness during sleep. They may show elevated beta, but that must not throw us off balance with regards to us thinking that we don't have a responsiveness to circadian rhythm. So we may not see that calmness during sleep hours, but then it might be observable that we see consistent wash in, wash out with medications. So that is again confirming. Of course, streaming can also be used in the clinic to check if we have dose-dependent response, and also the rebound to qualify the frequency of interest. So that is about the difference between GPI and STN. In terms of patient selection for the modes, I must confess that I only think of the beauty of single threshold from the point of view that both hemispheres get activated together. So for me, it's a wonderful mode where I get a boost on both sides or it decreases on both sides, which does not happen with a dual threshold, because each of them are independent in terms of how they adapt. So I would not know how it would translate to which patients benefiting from single or dual, but for me that one aspect is so beautiful, because the ability to fire both together and give a stimulation boost on both or decrease both together is so wonderful. And if you set it up on both sides, we have a higher probability of the stimulation adapting. If we set it up on only one side, then we are lowering that probability by half in terms of single threshold crossings. I would not know how it would translate to patient selection specifically. When I do imagine, but I do not know how it will translate into clinical practice. But that will have to be checked, because something happening suddenly, unexpectedly, requiring a boost, maybe a single threshold is much more able to deliver that boost, whereas a dual may not. Of course, there are some other parameters also which we can change, like the ramp up time and the ramp down times, in order to make the dual threshold more responsive. So I must confess, I do not know that.
I think one of the promising areas where single threshold is being studied is where, Dr. Vaidyanathan here. So one of the areas where single threshold is being studied is in patients with PD, with DBS who have gait and balance issues, because it's much more dynamic. And because the single threshold can adapt so quickly, it's more useful in that particular in those particular cases. For people who are just starting off, in the initial setting up of the aDBS, I just want to ask you, because with the electrode identifier, sometimes when you switch it on and switch it off, you can have a change in the contacts it detects, like 9 and 11 or 10 and 8. It has happened. So would you recommend going in for the vertical survey and the horizontal survey first, along with a monopolar review? I know that defeats the purpose of your automated system, because it will help identify based on the LFPs and based on some clinical data, rather than a completely automated electrode identifier, which can sometimes switch which is the ideal contact or on the electrode. That's one. And similarly, would you go beyond your 75-25 rule, again based on clinical reviews, rather than purely setting the thresholds on the 75-25?
My very naive understanding about frequency of gait is that it might be a decision issue more than a locomotor issue. I do not know, I just looked from a network perspective. So if it's something with relating to indecision, and those indecision networks are influencing frequency or freezing of gait, I do not know what mode of aDBS may be able to tackle it, because I think we currently think of it as a locomotor issue, and if we are able to do that, we must find a biomarker during that moment when the freezing is occurring. Only then can we respond to that, to be able to adapt to the need at that moment. But I don't think we are there yet in terms of finding out what biomarker is overexpressed at that moment of freezing of gait. We have a biomarker. There's a new publication which actually looks at all the different items of the UPDRS3, and they've shown that we have multiple frequencies which correspond to multiple aspects of the UPDRS3, like arising from the chair and every other subscale in there. So I do not know if frequency of gait would have other frequencies. I'm also compelled to think sometimes that this I'm sorry for being primitive in my logic. Like increase stimulation when something increases or decrease stimulation when something decreases, you may perhaps need another kind of algorithm which may work on a ratio of something or something of that nature, not a pure increase decrease type. I think that was freezing of gate. The other one, I think I forgot.
Just about the electrode identifier.
Oh, electrode identifier, yes.
Monopolar views.
Yeah, I apologize. I get carried away in my thoughts. So the electrode identifier is a monopolar referential recording approach which gives us an absolute value. You have two possibilities. One, you see the frequency plot which gives you the unprocessed data. The dot score gives you the processed data. The dot score removes the reference electrode influence from the calculation. The reference electrode is always the superior electrode on the contralateral side because it is far, far away and it is not influenced by volume conduction. It's not influenced by volume conduction happening from the hemisphere of interest. So that's why we have chosen another electrode which is 20, 22, 25 millimeters or 26 millimeters away because it's not influenced by volume conduction, but we still have to subtract that influence of the reference electrode, and by doing that we calculate the dot scores. If you rerun electrode identifier, it's possible that you get different dot scores if the patient state is the same. Like I'm assuming engineering wise, so apologies for a kindergarten approach, but if the patient state is the same, then I would expect the tool to be reliable, giving us the same dot scores. But in case it gives us a different dot score, I would expect at least the 3 dots and the 2 dots to be consistently represented. So the 3 dots and the 2 dots, those are the ones that we could select for a restricted monopolar survey. The 1 dot, any which ways, is that lowest minimum amplitude electrode, which is telling us that the source is far away. The ones that are 3 dots means that is the closest, 2 dots is medium close, and the 1 dot is relatively far away. So in the restricted monopolar survey, we could still include the 3 or the 2 dots. And then, of course, you also have this possibility to use the scrubbing tool and change the frequency of interest. And then as you change that, the dot scores will be recomputed. So I would not use that tool to select the frequency of interest, but we can use that in order to identify the dot scores if they're consistent or not. Yes, I agree with your approach of doing the vertical first and then the horizontal. So the levels first followed by segments. There might be a disparity between what you observe on levels and what you observe on segments. For segments, of course, I don't know, but the approach may not be to switch off the segment in the beginning, only switch off if needed, and and if you're compelled with some side effects, then only switch off and be ruthlessly reductive if necessary in terms of switching off.
Thank you.
I think we'll go for the next session.
Yeah,
thank you. I would like to call Dr. Kuldeep to present his case.
Hello. I would like to now call upon Dr. Arvind Prabhu to chair this session. He's Professor of Neurology at Kasturba Medical College, Manipal, and a Movement Disorder Fellow. Over to you, Kuldeep.
So, good afternoon, everybody. Talking after Dr. Swaminathan will be very, Vaidyanathan will be very difficult. He has gone into very hardcore places, but let me give my honest experience. Okay, we are all learning adaptive. So this is our Narayana Hridayalaya experience on adaptive DBS. I have very few patients, but let me show what was the thing. Okay, so first case, I'll just go on a case-to-case basis. So first case, this is a patient who had a PD at age of 50 years, and 8 years into the PD, he had severe tremors, and he had severe motor fluctuations and levodopa-induced dyskinesia. That is when he was convinced to go for the DBS. So age at DBS is around 57. So coming to the groups now, after going through the, we had good beta band and good scores on the LFP. So finally, I had, just to cut short, I had kept him on 3 groups because we need time to assess. So I sent home on 3 groups. The group A, if you can see, is the adaptive group. Group B was the conventional one. Just to note that group A, the adaptive group, he's a right dominant PD. So group A, if you can see that adaptive, I have kept around 2.9 and given him threshold of plus or minus 0.3 at that point of time. Group B was the 3.4. I went first with the conventional and then called him back for the adaptive. So group B was his favorite group before the adaptive. On the left side, on the right STN, which was non-dominant side, he didn't have much symptoms. The currents were same, so it is little lower. So it is comparable voltage compared to the dominant side, where the voltages we have kept is not comparable. So this is his mail to me. So he was mentioning that except tremor, all the other things are good in the new program, and he is more comfortable in the new program except for tremor. So the issue is that, but the tremor was his main issue. So we had to switch back to the old group. So one more highlighter that probably tremor is not well represented. But let us go to that may be one of the reasons, but let's discuss it in detail. So we are not judging anything here. Next, going to the next case. So this is the young onset patient, got a PD at 30 and 6 years of PD, DBS done at 36. His was like a mixture of everything, tremor and mainly severe motor fluctuations. So dyskinesia was not a major thing. So he was a young patient, so took him for DBS early because it was affecting his work. Now, this guy, just to show one of the LFP, the band. So we had good score on the LFP, above 2. And the other side he had a score of 4. So just tells that the biomarker was correct. And in his case, just want to highlight that initially I didn't get the LFPs. So this LFP was maybe, it was done long back. He's in PC. Then RC was also not there. So that 6 months window when PC was there and RC was not there, this case was done during that time. So we are doing adaptive after 1 year. After 1 year when I check, I find that the beta bands are good. So that was one more learning for me. In him, if you can see, again I have kept the groups. Group A was his favorite group, and you can see group C is the, I think this is not the one. That adaptive symbol is not there. But it was basically I wanted to tell that in this group also I had found that the voltages were little less in the adaptive compared to the conventional one. He also mailed me back that his body movements were getting slower and he had to move away from the adaptive group because of this. Now coming to the third case. This is a case which was done recently, 8 years into PD, that is at the age of 60, mainly for motor fluctuations. He didn't have dyskinesia, not much tremors. So again, this is on towards the lowish beta band on the dominant side, and on the other side also, it was almost towards the lowish beta band, which is 1.64, but still reasonably good. And in him, his favorite group was group A, and this I did simultaneously. Nearly there was no much gap between conventional. Pretty soon we also gave him option of adaptive DBS. In this, if you can see, the voltages where the current was similar, almost similar in both the groups. And then there you have kept the adaptive thing. These are my observations, just wanted to tell. So this patient tells he felt the same benefit in all the groups, but was saying that the swaying, he was not able to exactly tell. He doesn't have postural instability, but he told that some swaying was little bit less in the adaptive group. Probably it was referring to that mild dyskinetic pattern which he gets when he's on the conventional group, although he says that this is equivocal. Now, just to summarize these observations, so the difference, the reason for switching could be, because we are very naive in this adaptation, the difference could just be because we had, the significant confounding factor is that there is a huge voltage difference here between the reasons, so that could be one reason for him to switch. So optimizing and second point could be that optimization of the threshold is still very early. These are all patients who are on the first threshold itself. The second round of setting where we optimize the threshold, what Dr. Vaidyanathan was telling, we have to use the box method, these are all not done. So that may be another confounding factor. And I was keen on the point that one of the patients told that he had some vague feel-good factor in the adaptive thing, which he could not pinpoint. That may be the dyskinesia reduction, it could be the non-motor. These are the things we have to tap more. So we have to spend some time with these patients to figure out these things. So logically, adaptive DBS should be a logical or a scientifically it should be a winner compared to non-adaptive DBS. There's no doubt about that. It's probably that we need to adapt to the adaptive DBS to convert it into patient benefit. Thank you.
Thank you, Kuldeep, and I'll just present briefly our cases. We had done 20 cases, and of these we had activated aDBS in 10 patients. So this is our data. So we had done 20 implantations which were new. Of this, 16 we had done from the in the STN, and 4 we had done in the GPI, and battery replacements were about 5. So we had activated aDBS in 10 patients, and of these 2 were in STN and 2 were in GPI. And 4 were from the non-percept family. 4 persons who had activated aDBS did not come for follow-up recently, and 2 were clinically well, and so we did not switch from the conventional DBS to the adaptive DBS in these 2 patients. So the mean age was around 62, and the mean duration of PD was about 8.7 years in this. So what we did is, after the implantation, 2 weeks of BrainSense was activated. We waited for 2 weeks. And then after that, we activated the adaptive DBS based on the information, whatever we got. And all patients we tried only on dual throat threshold DBS. We have not put on any single throat aDBS at all. And lower and upper thresholds were adjusted according to the beta activity. We had only done based on the beta activity and clinical assessment. So this is the patients, 10 patients what we had tried. And the first column here shows the nucleus where it is implanted, the age of the patients, and the duration of PD. Most of them were more than 5 years. The max was about 10 years in, in some of the patients. The predominant problems what we were we are seeing before the implantation was done was motor fluctuations and dyskinesias in most of the patients. And these two here are the two patients who said we had improved in adaptive DBS, mainly in the form of dyskinesia. And these are the pink one is the two patients who told we had worsening of freezing after the adaptive DBS was activated. And only one patient told that some non-motor symptom was better, but there was no any change between the conventional DBS and the adaptive DBS after it was switched on. Rest of the patients, we had to go back to the conventional conventional DBS itself from the adaptive DBS because they did not feel good after we converted them to the adaptive DBS. So this is one or two stories I'll just share with you. So 42-year-old patient, 15 years PD, and he was on conventional DBS for about 7 months, and then later on we switched on once the adaptive came into the picture for about 4 months. So what his problems were that he had improved motor fluctuations, he had reduced dyskinesias, but he felt that there was no any change in his gait after the adaptive DBS was done. And what we could find was that during the night time, the adaptive DBS was consuming less battery. So this is one of the advantage what we found in this patient. So this is one advantage. So here are the settings. I'll not go into the detail because a lot has been discussed in the previous session for the want of time. And most of his thresholds were in between, sandwiched between the upper threshold and the lower threshold. And again, this is the graph just to show that what was the stimulation which was going above the threshold, what was lying between the threshold, and what was there below the threshold. So what we could see is in the left STN, we could see that more than 60% of the time it was between the threshold, about 30 to 40% it was going above the threshold, and less than 10% was going below the threshold. But on the other side, right STN, we could see that almost 90 to 95% was falling between the thresholds, and he was having very good improvement after the adaptive DBS. This is one patient who had very good improvement with adaptive DBS. And this is another lady who had PD for about 10 years. She had very troublesome motor dyskinesias, fluctuations, and after we implanted, we had not switched on the adaptive DBS. She was on conventional DBS. She had met multiple doctors for reprogramming outside. Again, she came back to us, and then we had to put her on the adaptive DBS. And what we could see was the dyskinesias what she had. I'll show you one of the video. This was one of the dyskinesias where she used to have very rapid dyskinesias and a lot of dyskinesia in the upper limbs when the conventional DBS was going on. So this is what, when the current was switched, increased to about almost like 2.8 microvolt when it was increased, she used to have this kind of dyskinesis. She automatically used to reduce the current and take more Syndopa because she used to feel better with this, because this dyskinesis was very troublesome to her. And then this is what happened after we switched on the adaptive DBS. She was completely good only on the dyskinesis part. She never had any issues. So she was the candidate who was very happy. After a long time, after the conventional about 18 months, we switched on the adaptive DBS. So she had good improvement in the dyskinesias. Again, I'll not go into the minor details here. And she was in between the thresholds, upper and the lower thresholds, what was set clinically. Again, this is again the graph showing that on the left STN, most of the time she was in between the thresholds. On the right STN, the thresholds were only between 40 to 50% or maybe 60%. And below the threshold was seen on the right STN where the disease was actually less on the left side where the right STN was stimulated. So most of the time it was below the threshold. So this required a little bit of optimization. Again, these are the two patients where we activated adaptive DBS where the gait problem became worse than the conventional deep brain stimulation was going on. He could not even walk few steps, which he used to do before that. And this is the other person where his gait became very bad after the adaptive DBS was switched on. So these are the two patients who did not do well. We had to switch them back to conventional DBS, and they were better with the conventional DBS itself. So these are the results what we had. So I think we have, probably I learned a lot after this session. Probably learning is going to make us better and better. So with this data, I'll stop here because of want of time. It has helped in some patients. It has not helped in other patients. Some have gone back to the conventional DBS. So we are really not there to say which is the right patient for us to program at Adaptive DBS at this point of time. So with this, I'll stop here. Thank you.
Good afternoon, everyone. So it's a time to honor our esteemed speakers for their invaluable insights and contributions. May I request our dignitaries to kindly join us on stage to present the mementos as a token of our sincere appreciation. So please join us in giving them with a round of applause. I would like to call Dr. Satvik Shetty on the stage to provide the appreciation to Dr. Swati Nair. Let's have a big round of applause, please. Dr. Swati Nair. Okay. Dr. Vikram Hola. Dr. Pramod Pal. Dr. Milind Deogankar. And Dr. Aditya Kulkarni. Now I would like to call Dr. Anurag Saxena on the stage. And, we would like to call Dr. Janardhan Vaidyanathan, Dr. Rajesh Iyer, Dr. Sanjeev Sisi, and Dr. Shabri Krishnan. We would like to call Dr. Arvind Prabhu on the stage. Thank you so much, sir.
Thank you.
So thank you. We'll go to the next section.
Okay. Now it's time for the panel discussion. I would like to call on the stage Dr. Milind Deogankar, Dr. Ravi Gopal Verma, Dr. Dwarkanath, Dr. Anurag Saxena, Dr. Raghuram G, and Dr. Nirmala S. And Dr. Vishwas, please.
We have 5 plus 1, 6. And because of the paucity of time, I think I'll try and get a move on some of these proceedings. This is a panel discussion where we're discussing asleep versus awake DBS workflows. And to start off, Dr. Dwarkanath, if I might ask you this question. You know, proponents of asleep DBS, they argue that intraoperative imaging is more than enough to place a very accurately placed lead, whereas people who do the awake DBS, they say that the anatomical location sometimes does not definitely guarantee a good outcome. You need clinical physiology as well. So, in that respect, does an anatomically perfect trajectory in an asleep patient match the clinical efficacy of a physiologically verified trajectory in an awake DBS case?
So, that actually is the question which you're wondering, whether physiology is required or not. So over the last 20 years, for which we have been doing deep brain stimulation, in our own data, I mean, we started off with 5 leads, penta electrode recording. But the problem with the old drives was that the inaccuracy was slightly on the higher side. So we had, and there also used to be the problem of brain shift. There was no glue available in 2000s. So we had to use all the other methods like putting some cotton, keep on irrigating the place. So there was always a tendency for the brain to shift, and so we were always worried whether it is actually going to be accurate, especially on the second side. I mean, almost 20% of our leads which we positioned in the first 8 or 10 years were in the non-central lead.
Okay.
So when the new drives came out, especially over the last 4 to 5 years, and with the advent of glue and all the other things, the incidence of brain shift has significantly, I mean, minimized. But the question is now whether we are going to do for GPI or STN. So GPI, what we have done for dystonias, almost all are asleep. And we've had very good results with dystonia. I think we have one of the largest series of pediatric dystonias in the world. We published our data in JNS and child nervous system. So the data is very robust. The problem is with STN and Parkinson's. So even the case which we did on last Tuesday, we did the median implantation for one and we did the central implantation for the other. Even though we got robust recordings in both, but when the neurologist came, and I think Vikram is here, Vikram does most of the intraoperative recordings along with the residents, and so many of our PDFs are very accomplished neurologists today. So they will tell you that there is another 10 to 15% of the cases in which, even though the recordings are robust, the clinical response is better either in the anterior or the medial. So with experience, we have done away with 5 lead recordings. We generally do 2 or 3, depending on the anatomy. But there is a percentage of 10 to 15% where we don't place it in the central lead.
Right, and so do you audit where you place the lead versus the outcomes?
So what the neurologists say and what based on their intraoperative assessment, we either place it in the medial or the anterior one, which generally is the usual thing for STN.
Okay, right. Thank you for that. Dr. Diyagankar, now if you choose to predominantly do awake DBS, are there categories of patients that you faced difficulties in performing the surgery? Or conversely, what do you think would be your indications for performing a sleep DBS? So if there are patient factors or target factors, could you tell us more?
No, no target factors, only patient factors. Young children and patient who is really anxious and likely to be not cooperative, especially psychiatric issues, and I'm doing unilateral, but basically patient issues. And we done a child with KMTB2 who is 2 years, 3 months old. So young children always under GA. Otherwise, all under awake, and all with mapping. With under GA or without GA, we still map one electrode only. That's it.
And what about patients who are in a more advanced stage of Parkinson's? So they're more, their speech isn't intelligible, so their clinical response isn't as good. Not just the anxious patients, but also, and do you look at patient experience? Things like surgical duration and cost as factors as well?
Yeah, I mean, you're right. And so patient factors are the only factors which will drive you to do the sleep DBS. And as you said, yes, advanced PD who are not able to tolerate staying awake for a long period of time, they request general anesthesia, asleep, will do asleep. Because bottom line is, there is no difference in outcomes whether you do asleep and awake. We have our own trial. We had done a trial long time ago, 2005, OAM guided against asleep, against awake. There was no difference. I mean, all these years, these DBS neurosurgeons are fighting over GPI versus STN, asleep versus awake. Marwan Hari stands up and says, awake, awake, awake. Someone like Jerry Wittek stands up. I mean, Marwan Hari stands up and
asleep.
says, no recording, no recording,
Yes.
no recording.
Since 2002 at Queen's Square.
And then people from Grenoble or other US centers say, no, recording. I think recordings are good in initial part of your career if you are becoming a functional neurosurgeon. It's not necessary for patient. It's necessary for you to really understand the 3D anatomy and how changes happen if you move 1 millimeter lateral. So 100 dBs down the line, you can put in a DBS asleep without mapping as effectively as with mapping and awake. So I think it's just patient factors. Otherwise, accuracy is the same.
Right. But Dr. Anurag, how would you weigh MER recordings versus intraoperative and intraoperative stimulation against direct image-based targeting now? And if you were doing a sleep DBS, would you do pure sleep DBS where it's completely image-guided, or would you combine some MER or mapping?
See, as far as my practice is concerned, I would like to be, do a hybrid approach. So, especially in dystonias, when we are doing a sleep DBS, we like to see the brain, as I call it. You see the MRI, you see the target, and you localize it, and you have to hear the brain, which is MER. And then at the same time, you do some motor mapping as well, so some twitching and other things, because of GPI, you have to give a lot. The stimulation parameters are huge in dystonias as compared to STN or a PD or a VIM. So that is where I would like to do both. But in certain cases where, as has been discussed, where anesthesia has to be short, you don't want to take more time, and your MRI shows that the target is bang on, you have intraoperative imaging, I would like to go straight away. So as I said, it has to be tailored according to the patient and the case, what we are doing.
And does it matter, because in this day and age, you have really good 3D imaging, great planning systems, and you have directional contacts. So would you be more confident just doing it purely image-based?
Yes, in certain cases, definitely. Yeah. So if, as I said, again, patient is, unless your anesthetist is able to tweak the anesthesia properly, then MER sometimes, patient is on a lot of SIVO or propofol, and the MER you're not getting, then you become anxious as a surgeon also.
Okay.
And then certain cases where you tend to, you went to quick in and quick out with directional leads and good intraoperative imaging. And now with this 3D mapping coming up with like other systems, other companies are coming up, it is pretty much feasible to go directly, and I've done that as well. And with pretty good, as Dr. Sabha said, that there are no differences in the results. But you have to have some sort of a physiological feedback when you are putting an electrode.
Right.
That gives you an extra stability. One more thing I like to add is what we are not discussing here is there are some medical legal aspects as well. So if you are doing an MER and if you are not doing an MER and the patient ends up with a, or you are not doing a motor mapping and patient ends up with a complication of a motor, maybe a facial twitching or a dysarthria or anything. And then the question arises, why didn't you do it in the first place?
Okay.
So you will say a lot of literature and everything, but when that modality is available for you to monitor, why didn't you do that in the first place?
Right.
That's the first question which arises. So a lot of things goes into the decision factor.
Okay. Dr. Vikas, now over to you. Are there any specific targets where you believe an awake approach remains absolutely non-negotiable? Like if you're doing WIM DBS for essential tremor, or do you think that now that we're doing GPI as well as STN asleep, even that will shift? Are there any target-specific scenarios you can think of?
Hi, and I'm Vishwas.
Sorry, Doctor. My fault. Sorry, Vishwas. Dr. Vishwas.
Targets where awake is compulsory, yeah, probably when you're talking in terms of tremor. Again, you're talking in terms of WIM thalamus, or again, you're talking in terms of dual targeting, in which you're trying to use a lead which is going from your WIM thalamus going all the way to the posterior STN, where you want to get a good ZI included into your listing, especially for complex tremors, where you have a bit of cerebellar component, where I think an intraoperative examination of the patient gives a very good idea and a very good clarity as to what you're looking at. So the neurologists there, especially with Boston's MICC, they can decide on which are the two contacts they can stimulate together to give the best recovery or the best improvement of a complex tremor in the patient. So those are the patients where I would say that awake is essential. Yeah. The rest of the things, I think all the points have been covered very beautifully.
So I know you at Liverpool where you were working, they do put those long leads with the 8 contacts. Yeah. But does every patient with an essential tremor need contacts going from the WIM all the way to the zona inserter?
No. We were also the center which had done the maximum number of MR-guided focused ultrasounds. So people who had a very specific essential tremor, they would be primarily more candidates for ultrasound, MR-guided ultrasound, where they would be getting a good outcome with that itself. Whenever there was always a debate in your MDT, where it's like, is it purely that, or is there some other components of the tremor that are getting included? Those are the patients whom we would always prefer to have a dual targeting, so that you have the programming advantage if that, okay, thalamus is not working well enough, we have other areas to stimulate and see how it goes. So if you are confused in your diagnosis, it's a long discussion in your MDT to decide who will require.
And that's primary insertion itself, not initially try 4 contacts, then put 8 contacts?
No.
Okay.
We would always put the 8 contacts. I mean, currently the directionals are also 8 contacts, but I'm considering the 8 long contacts, monopolar leads, yes.
Thank you for that. Dr. Nirmala, could you tell us, in your experience, what are the complications or the risks that you see or the disadvantages between the asleep versus the awake? If you could tell us, talk about both sides.
Grossly, there is not much of difference between the complications as asleep or awake, because most of it is depending upon how we plan. Most of our complications are mainly hemorrhage or venous infarct or whatever it is, it goes on our planning. We are only looking at whether intraoperatively we can use MER when the patient is asleep. So now there are a lot of anesthetic techniques where they can bring them to a near awake state. If they use BIS, they can actually get them to a near awake state where we can do an MER. Now, if we say further going beyond that, now if we really want to say whether we are in the right target and are we giving them complications of neurological deficits in the form of stimulating the internal capsule, after we have placed the electrode also, we can actually use the external nerve stimulator, check on all the directions of the lead itself, which we have placed, to see whether there are any deficits. So as such, complications wise, both awake and asleep will have
so
the
things like asleep having a fraction more anesthetic complications, or awake having a slightly higher chance of hemorrhage, because on average, if you look at data, it's about 1.4% chance of hemorrhage per lead. and you have more lead insertions in the MER because you have more microelectrodes versus a single blunt mandrel going in the asleep DBS, and pneumocephalus because it's a longer procedure. Do you find nothing significant?
I don't think so, because ultimately, even if you're looking at pneumocephalus, it's the dura that we are opening, whether it's awake or asleep. And the number of electrodes now, like what Dr. Dwarkanath said, previously we used to put 5 MER electrodes. Now we have boiled down to 2 or 3 or sometimes 1. Like for GPI, even 1 should be enough, central electrode.
Right.
So I don't think that should be a major
valid,
problem.
and I think it comes with experience as well, that you can choose just 1 or 2 out of the 5.
Yeah,
electrodes.
basically the complications are how we plan.
Right. Thank you. And Dr. Raghuram, now Dr. Diyogankar has already said that functional outcomes on the UPDRS3 and force, the stimulation parameters, the STN firing rates, burst indices, all of these on multiple studies basically show that awake versus asleep, there's no significant difference. We've had the Montpellier groups in Canada, the US, Chicago, and so on. So awake DBS still seems to have better 3-month or the short-term scores on the UPDRS3 and a lower daily case. And is that more important than... Okay, I'll come to the next part of the question. Let's finish.
So I think this is like you clearly said, so it's a debate that's been going on forever, like what Dr. Milind said. So we have enough data to say both. But there are 2 important things that I want to, suggest that. See, if you have a neurologist who is a very active movement disorder person, he would want to be in the OT, right? He would want to be in the OR for him to see that MER. He wanted to be in the OR to do the macro stimulation and see that response. So all this, what happens to you is that you get extra confidence. And for him, when somebody who is going to be taking care of this patient for the rest of the patient's life, is very, very important that he gets that confidence, okay? If I tell him that I'm just going to put it in 20 minutes in the OR, make a single bar hole, single trajectory, and subsequently he has to manage, he has to obviously has that constant doubt in his mind what happened during surgery. So that is important for functional neurosurgeons, especially if you have an active movement disorder person, to make sure that they get that confidence so that you have a very good, successful program. Okay. In addition to all the variables that, like you said, MER, right? So nowadays, if you have a center which is relying on a capital equipment that is being provided by the company person, for various reasons, may not be just the fact that your hospital is not ready to invest in the infrastructure, or maybe a reason that you are having a situation where the numbers are not so high. So then what happens, there are so many things that can happen wrong in a stereotactic surgery. Even though we all know that, it's not the glamorous part of neurosurgery, right? Unlike an aneurysmal surgery or a skull-based surgery, we all know as functional neurosurgeons for a long time that there's so many minute details that can go wrong, right, when you do these surgeries. So if you're just going to blindly trust your stereotactic apparatus, which may not even be your own, which is something that has traveled far and wide, multiple usages, multiple kind of nurses handling it, so then you may have a challenge when you just do it asleep, because you're not confident of all the accurate checks that has happened. This is something that you may be a very good surgeon, you may do it perfectly, but if the equipment fails to match your skill, then you may have a challenge. So that's another important thing. And in terms of, definitely if you use multiple trajectories, like Nirmala said, there is a small increase in the risk of bleeding, even though you may plan accurately because of the same reason, brain shift, pneumocephalus, there may be these minute changes. You may have said that I will not use medial, but I will do central, but that central may actually be medial.
Yes.
And you can still have a bleed and all that. So that way, maybe the better response could be because of microlesion, but like you said clearly, in the long term, that doesn't really translate into any better outcomes just because you're doing awake or asleep.
Okay. I'll let you hold on to the mic for a follow-up, but because you've done so many cases, and it's also open to the rest of the panelists, in your experience, because there are still reports which say sleep is better, in long-term studies, cognitive and the dementia rating scales have actually improved in the asleep DBS. That's the one advantage that some of the studies say. Has that been any of your experiences?
I mean, that's not really related to we have done a lot of cases. In the initial phases, we used to do a lot of STN, and now we are doing more of GPI. So I don't know whether this particular study is specific to a target or is just a generalized study of both STN and GPI.
I think it was mostly the STN.
Yeah.
Asleep
so
versus
we know
awake.
that now with enough evidence that when you do STN, there is a cognition issue that can happen subsequently, whereas with GPI, that is taken care of. So many of us, our own colleagues, when the patient is elderly, we are now tending to do more of GPI. I am sure Dwarka has.
Yeah, I mean, I agree with what who says. Older patients now, I think about 60, 65 we are shifting to GPI. Younger patients, tremor predominant, severe dyskinesias, we are still sticking with the STN. But this is a very interesting fact which I think I'd like Dr. Milind to comment. I mean, we have written enough academic papers on how statistics can be manipulated. And statistics are basically, I mean, you can take, there are 10, 15 different statistical methods. And if you're doing one technique, you can use your statistics to present data however you want. So that is the biggest fallacy about statistical analysis. And believe me, I've written enough papers to know about it. So what happens is, when we say that there is no difference between asleep and awake, even in real life terms, if you see our own data, 85 to 90%, we are going to put it in the central lead. The question is, this sample is a large enough sample which obscures or changes for the other, makes up for the difference in the other 15 patients. So if you're doing 1,000 patients or 100 patients, you have 85 patients who would have had the same target whether they were done asleep or awake. But there is this cohort of around 10 to 15 patients who would have been different if you had done asleep versus awake. And these 15 patients actually are never analyzed separately in any statistical data. It is always 100 versus 100. It's never 15 versus 100. So that 15 patients is what troubles me. Are they having optimal outcome? What if you had done intraoperative electrophysiology and done intraoperative mapping and put it probably in the medial one or in the anterior or in the posterior, whatever, and not relied on radiological landmarks? This question will never be answered because no statistics ever capture this 15% as a separate subgroup cohort versus all studies. I think Dr. Milind will say, I think even his own study, it was always 100 versus 100.
Right. Dr. Milind, do you want to add anything to that in terms of the mood and cognitive outcomes as well?
I think what he's saying is right. I think it matters in small percentage of patients if you are mapping. But I mean, it also depends on what kind of conditions you are provided with, like Dr. Raghuram said. If I'm in West Virginia University or OSU or Cleveland Clinic, we had 5 stereotactical Excel frames managed by only one nurse. No one else will touch it. Calibrated every 3 months. We had 2 MER sets of our own. All our patients underwent MRI scans, 7 Tesla or 3 Tesla with DTI. So I could see the DRT, this cerebellar fibers going into the VIM, and I could target just that. And I knew there is absolutely no magnetic warping because only one person would put on the frame every day. Those conditions I wouldn't mind doing our asleep DBS. I mean, the same outcomes.
Okay.
Even no 15%, 100 to 100, same outcomes.
Right.
What matters is, well, while practicing here, this is what I realized, that there are so many pitfalls. And unless you account for all of those, I mean, you can really get the lead in the wrong place. As Dr. Ghuram said, you might be a great surgeon, but that the tube that comes with NeuroSmart, if it is used multiple times by Medtronic before and it's curved to one side, your lead will go 1 or 2 millimeter lateral or medial without you realizing it.
Right.
And ENS is not there all the time. So yes, whenever you are in doubt, when you are not 100% satisfied with your surroundings, whenever you are not 100% satisfied with your own skills, it's better to map, better to have a physiological feedback.
Okay.
That keeps you, your neurologist, both happy that, okay, I got 7 millimeters of STN, there was good movement driving, I got good response, there was no capsule up to 5 volt, everyone goes home happy.
Right. And if I could end with a question on some special indications. There are rare cases where I've seen 4 leads being put in, 2 in the GPI and 2 in the STN. Longer duration of surgery, would you do that asleep? And the other case scenario is redo cases, whether, after some time you think it's not optimal, you want to reposition that lead. At the centers which have great experience and consistency, like you mentioned, Cleveland Clinic or Queen Square, they will still, I know for a fact at Queen Square, they'd still do it asleep, even the reposition. Whereas, would you think that if the leads aren't optimally placed, when you redo it, you'd shift from asleep to awake?
Depends on where is the reposition. I mean, if you have done the case yourself, and you know you are getting strong capsule, and you can do a MRI scan, impedances are normal, and the lead is 2 millimeter lateral only, then you can just give full anesthesia, take out the lead 2 millimeters at least, because the metal cannula needs to be 2 millimeters to be away. If it's less than 2 millimeters or it's a complex small placement, it's better to take the lead out, wait for 3 months, let everything heal, map again, and then put the lead in. So, but I mean, like he was saying in Vim, I mean, you are getting VC stimulation, strong paresthesias. You just have to move forward.
Yeah.
Then you don't need to map. You
Absolutely.
can just go 2 millimeter forward and drop it.
Right.
But if you don't know where you are and nothing is happening, it's better to take the lead out, wait for 3 months, and then map. Complex cases, it's better to map. Having said that, these newer targets like nucleus accumbens, we have done a lot of nucleus accumbens, we always do asleep. I mean, initially we did awake and patient used to feel this rush of happiness, and then we stopped doing it. Even Sante trial, I mean, all the anterior thalamic nucleus DBS we are doing asleep. CMPF DBS we are doing asleep. So all these obscure targets, PPN also, whenever we did generally secondary to STN. So patients already used to have STN DBS, and they will just add 2 PPN leads, and we done those asleep. We never mapped for PPN. So all the targets that does not have proper mapping indicators, better to do them asleep.
Okay, right. Thank you so much for clearing that up. Are there any questions for our panel from the audience? If not, gentlemen and Dr. Nirmala, you've done a fantastic job clearing up our asleep versus awake debate. Thank you so much to all the panelists.
I request to stay back for a minute for the memento. I will invite Dr. Veeresh to come on the stage for memento. Dr. Milind, sir, please. Dr. Darkanath, sir. Dr. Raghuram.
Dr. Anurag Saxena. Dr. Nirmala. Dr. Vishwas. And Dr. Nishchit Hegde.
You have to keep the background conditions constant.
Thank you. Thank you. Now we'll go to the last session, and I call upon Dr. Guru Prasad sir to please come onto the dais. Dr. Anish Mehta. Dr. Vikram, please come. Dr. Arvind Prabhu.
I know. We have done all one, sir. We have done all one. Guru Prasad. I know. Theory, practical. Theory, practical, we can answer, sir. We just... Theory, okay. Questions.
Sir, I'll keep it very simple. Okay. Dr. Kuldeep, please come. Sanjay. Yaru? Sanjay Sisi idara. Dr. Sanjay Sisi sir. We are going to discuss among ourselves. Hey, Sanjay. So very practical question. I'll just start from Kuldeep. So how do we set the lower threshold when we choose adaptive DBS?
So many times, so there are two ways. So one is that in the earlier thing we had a confusion that when you set the thresholds, you go by the opposite of the thing. So here also, like the upper threshold is corresponding to the prior to aDBS, the upper threshold corresponds to the lower most this one at which you get the positive benefit to the patient, and the upper threshold used to be that where you start getting the highest amplitude at which you don't get any side effects. Okay, but now with this thing, we use the similar thing, but when it comes to the numbers, we get two different kinds of numbers. One is that upper number, which is in the higher side, and lower, something like hundreds, 900, 1000, that is in the higher side. So that sets the upper limit for the, that is the threshold at which you can stimulate without any side effect. And the lower most number will be that the first sign at which you start noticing the benefit.
Anish, I know you had gone to South Korea for attending a session on adaptive DBS. So your opinion on that, how do you set, what is their opinion on that?
What, sir?
Lower threshold and upper threshold in clinical, clinically how do you set? I mean, there is no defined protocol or criteria, if I understand in all the studies what I have done.
Yeah.
How do you set? Some say 50% of the level of the upper benefit, some say you start getting the clinical benefit, you start the lower threshold. So where do you set the lower threshold and where do you set the higher threshold?
So, sir, if I'm switching from conventional to adaptive, so first I see where is the response at the conventional DBS. Say, for example, if he has a 2.4, and then we switch over to adaptive. So again, as Dr. Kuldeep said, the higher threshold will be where I start seeing the side effects, and the lower threshold will be where I lose the response, but at a point where I get the first response, that will be my lower threshold. So in between that 0.3, 0.5 is where I set the
Any other opinions?
So basically, one thing is you need to do this during the lead-up off state. The thresholds are set based on the LFPs. So you look at the timelines, and then the 75% of, like Dr. Vaidyanathan was mentioning, if you go to the ADAPT PD trial, they have done a little differently, that you do a lead-up off state, and then look at the timelines, and then 75% of the 3-day at least average, that will be the upper threshold. In setting the lower threshold, you need to switch on the thing. You give the medication that is on medication, then 25% of the LFPs, where you get some response. That is the lower threshold. Whereas 70% of the higher the LFPs, what you see, average out, and that will be the upper threshold. They say sometimes 50% also.
Okay. Vikram, I mean, I was studying a little bit about this. So what they say is, The beta bursts are not important. The change of duration of the beta burst is the next emerging concept in the LFPs, what is happening. So you are measuring the change of the beta oscillations. If the duration is more than 1.2 millisecond, that's where they say probably it is abnormal. Less than 1.2 millisecond is normal. So that is an emerging concept. So can you throw a little light on that?
Yeah, I mean, the beta, I mean, the broad beta or the beta duration, I mean, like that has sort of a bit more sort of replicable, and also, I mean, the reduction in the, I mean, as I think Dr. Jonathan was telling in the morning, that this is sort of noise and it restrict, I mean, even despite the movement also the beta doesn't come down, or I mean, it should come down usually, but it doesn't come down to the extent that we expect in a normal sort of individual. So, I mean, that's what the duration, even for the actually in the high, I mean, there was a discussion about the high threshold, I mean, single threshold one. So, even for freezing and gait impairment in postural instability also, they have seen that in the single threshold, it was the beta, I mean, whenever the beta duration was beyond a certain limit, the stimulus used to come. And if it was reducing below that, then, I mean, the gait, the freezing was a bit better whenever the, I mean, like with this modality compared to the amplitude, because the amplitude may vary a lot, I mean, based on the state of the patient and the movement at all, but the duration is usually slightly, I mean, resistant in that manner. And also, as in the morning, the gamma, I mean, that is even more sort of entrained gamma, and the gamma activity that is even more sort of robust and maybe more reliable marker, maybe that will come up in the more promising about the gamma activity, even more than the broad beta.
So, Sanju sir,
this thing there, what I mentioned is, first you study the conventional DBS. Take an average, what is the minimum threshold amplitude and larger amplitude. In between, you should take an average and feed sometimes to the AA. Then you'll get a preferable setup for the coming adaptive DBS.
So even, I mean, the funda of adaptive DBS is like, I mean, we want, I mean, although in the beginning we set a very sort of narrow, I mean, limits, I mean, the upper limit and the lower limit of the stimulation, we want it to be as broad as possible, I mean, without causing, whenever the stimulation is high, causing side effect, whenever the stimulation is low, going into the off state, so that, I mean, the fluctuations replicate the requirement of the body. So if we set a too narrow limits, I mean, I'm talking about the stimulation, upper limit and the lower limit. If you set a too narrow limit, it is as good as continuous DBS. You are not making use of the adaptive DBS feature. So it has to fluctuate as the day progresses with the medication, with the off state, on state, all those things. Then only, I mean, okay, I mean, we are using the adaptive DBS modality rather than just, I mean, activating it but not actually using it. I mean, just keeping it narrow. But we have to start narrow but make it as wide as possible. That is why the lower limit is set at when the patient is in on state with medication but not causing dyskinesia, so that, I mean, we know that is the stimulation the patient can manage well. The top limit is when this patient is as maximum as possible but without causing side effects. So they can fluctuate quite a lot. And the ramp is very slow, that doesn't cause too much of a problem.
In terms of stimulation, I think traditionally they say -4, +4, -4 for the amplitude setting for the stimulation, whereas we are talking about the thresholds.
Yeah, regarding the threshold, I mean, as Guru sir told, there are two ways. Like one is that I mean, in the Medtronic, if you see first, you activate the upper limit, and that will 30-second average it will take, and that will be the lower threshold, and you activate the upper stimulation limit and take a 30-second average, that will be your lower threshold. So this is, but in the timeline it will be more better, because you are seeing a longer duration and fluctuating with the sleep, fluctuating with the activity, fluctuating with the medication status. And as much as possible, the middle should have some 50% of the activities. Some of the outliers may be there too high, too low, that we have to, I mean, consciously ignore. And there should be, as mentioned in the morning, definitely the sleep has to be below the lower threshold. And there should be some of the, I mean, recordings that are definitely below the lower threshold. So, I mean, and that also, it should not be too broad. Then the patient will always be, there will not be any, I mean, the adaptive DBS, the stimulation should fluctuate. I mean, again, as per the theoretical. So there should be stimulation fluctuation over the day. Then only it is sort of adaptive component of the DBS is coming into play. If it is stuck to the bottom or the floor or in the same level, then the patient may be doing well, but still the adaptive component is not activated. I mean, we are not utilizing the adaptive component. So threshold should be in such a way that it reflects the patient's sort of activity and also the drug and the other events.
One more additional thing, what is this, because when we introduced Adapt DBS 3 months back, some of the patients who were supposed to come with the timeline data, they didn't come. So dual threshold, we need timeline data. Whereas for single threshold, you don't need timeline data. You can do real time. You can ask them to stream it and then see the averaging and then set the threshold. Whereas for setting the dual threshold, better to have timeline data. You can do without that, but ideally you require timeline data. At least, as I said, 3 good days of data for setting the upper and lower threshold.
One other problem what we were facing is that when they were on conventional DBS, whenever they used to go into little off, they used to use SOS Syndopa, or someone used to abuse Syndopas. We have come across so many patients like that. So when we switched on from conventional to adaptive, they were doing the same thing and actually they were becoming bad. So because probably the adaptive also was stimulating or changing the parameters, and they were taking the Syndopa also. So we were seeing a lot of worsening happening. Any experience on that, Arvind Prabhu? You have anything?
I don't have experience on this.
So this is what I've seen in 2-3 patients where, I mean, you tell them to stop Syndopa also, they don't stop. And when they take, they had a lot of worse dyskinesis after that. Anything on that?
Yeah, so the disadvantage or the limitations of Adapt DBS is you can't adjust the amplitude like you do a conventional thing because you have to pause the amplitude. You can't go up or down. So the amplitude is set, that's it. You can't do that thing. They have to come back again, then you can only do on your programmer. You can't set the thing. That's the reason why I think these problems you will face.
Okay. So, I mean, to come to, I mean, the end, which is the right patient you feel is for adaptive, which is the patient who is not right for adaptive at this point of time? All of you can contribute, please.
So basically, I feel any new technology is available. I think you should use it in all patients. Whether those patients will benefit or not, only time will say. What I'm doing in my practice is because we have the advantage of having 4 groups. Now we also have the image guided. The Boston Scientific also is now giving Ilumina. So that is also almost similar to what we are doing. Basically, it's more 3D mapping, image guided programming thing. So that also sets in the parameters. Same thing with the sensing or Adapt DBS. So whatever patients you're doing, best is to wait for 1 month and then take a trial, do a sensing initially, and then use all patients, whatever you have done using a sensing lead, give them the trial of 1 or 2 months. And I think you'll be surprised sometimes which patients I felt will not work, it worked. For example, one patient you showed mood changed. One patient we had, motor-wise she was doing well. She was not motivated, she's very apathetic. And we tried everything, vertical steering. I don't know whether we did horizontal steering. We did everything possible, but it didn't work. I mean, she was walking well, everything well, but not motivated. She's not ready to go to kitchen, not socializing and all. And for our surprise, we put her on Adapt DBS. The current required, amplitude required very small, and she did well. It's very surprising. So I think I don't think there's any ideal patient for Adapt. All patients who have sensing lead should be going for Adapt. You can develop your own experience, and then whether they'll continue for long on Adapt DBS, only time will say.
One other problem what we face is we have a asymmetric disease. So the STN which is more diseased shows better beta activity. The STN which is less diseased shows less beta activity, if I'm right. And so one side we will be able to use the adaptive for better programming. The other side we are not getting a good beta power. What to do in those situations?
But I think you have an advantage of using one-sided sensing or adapt to target bilateral. I think that advantage is always there.
Yeah, I mean, I think that is the, I forgot the word. I mean, you can refer to the contralateral sort of.
That means same settings you're going to use on the other side also.
Yeah, I mean, the threshold, everything can be used. What is the stimulation, you can definitely change between the two sides. But the threshold and all, you can depend on the contralateral beta power for the threshold trigger. Like beyond this threshold, you increase, and beyond
so
this
that means whenever someone is starting, you have one side good beta, you don't have on the other side. You extrapolate these settings to the other side. That's what you meant.
Other thing
Huh.
dominant side you can use adaptive, the other side you can conventional low current.
Sir, I
because
think
most of the PDs are, majority are asymmetric, at least a good chunk of them. Many times only the dominant side if you control, they are happy. So that side you give adaptive, the other side you keep low current.
Yeah.
So
The
I
other
think-
problem is,
I think as sir told, there is no ideal patient currently as we are just getting into adaptive DBS. But the challenges what I'm facing technical and more clinical challenges is, one is you can change only the amplitude. I'm not sure if you can change the pulse width and frequency with adaptive DBS. That's one. Second is you can
Yes,
see
you're
only
right.
the middle two contacts, not the upper and lower contacts.
Correct.
So that is another challenge.
Limitation, yeah.
Yeah, that's the limitation what we face.
Few more limitations is the highest frequency you can achieve is 185. You can't go beyond that. Someone who's got on conventional DBS is on 220 for tremor control. You can't use more than 185. Then pulse width, interleaving. You can't do interleaving. For example, someone wants higher current delivery. You can't do that. So you can only use monopolar thing. So there are some disadvantages.
Yeah.
That's why when we were in Bangkok for a meeting, Dr. Fasano was there. We were saying, have a formula. For example, someone who's been on conventional DBS for 3 months, 6 months. If someone has this type of parameters, you need to factor in. If you only look at the thresholds, then you may not get a good result. So I think we need to factor in what was the frequency, what was the previous one, and then factor in, and then adjust accordingly. Then I think probably we'll have better outcome. Otherwise, like you said, I had the same experience. Out of 10 or 12 patients we put on adaptive, only 2-3 patients continued to be on that. Most of them didn't have problems. Like they had gait issues, they're getting frequent on and off. So I think we again went back to things. So I think there's a learning curve. I think better
It will
to
take time to understand.
Unpredictable on and off, sudden on and off, those patients may be benefited with adaptive.
Okay. So we use rechargeable, we use non-rechargeable. Someone who is on non-rechargeable, you feel adaptive is better because battery saving, life saving is better in adaptive?
I don't know.
Yeah, that's what I wanted to know.
I always feel that conventional is more of a, you can say probably it's a manual mode of car. Adaptive is more of an automatic. Mode of car. So always automatic takes more petrol. It consumes more petrol than the manual one.
But
Fuel
what the
efficiency
data,
is
the
more.
RCTs
So
say
why I
that-
feel
yeah.
adaptive, I don't know. I mean, they claim that the battery may go less, the fuel efficiency is better. But the point is, it needs to sense so frequently and processing needs to be so much. So I don't know if the battery fuel efficiency is...
evidence says otherwise. Basically, what they showed in adaptive is almost 50% savings on battery. But I agree. I agree with the thing. We don't know. So, as Dwarka was telling in the previous, the statistics always tell you something, and in practice it's different. But I feel I would, definitely be, hedging on RC, rechargeable battery, because there's so many permutation combination you want to check, you want to use it. I would probably prefer RC, be comfortable with RC than PC.
Okay. So last question now. What is the greatest hindrance for you to adopt adaptive DBS at this point of time?
First, I think for greatest hindrance is first the placement of the leads. If the leads are not properly placed.
No, everything is perfect. I'm only telling about the programming part. So what is the hindrance for you to adopt adaptive DBS in your practice at this point of time?
Only as of now, I find only cost. If available, I would definitely use the adaptive DBS. Because now we are only using the beta band frequency for predominantly. We don't know what are the other non-motor bands or these are working for other non-motor symptoms. Plus, we are not checking with the, as I told, what frequency, gait, axial symptom scale. So that I think with the adaptive DBS, we can pick up more using the AI, the more data which will be available, like gamma and this, though they have not been proven. If we get more data on that, then we can use that. That is the only hindrance, cost, otherwise nothing else.
I think it's the most challenging thing is the time required. So I think our job has become extended and our time spent with the patient programming is much more. I mean, of course, the team from Metronics helps us, but they are not available all the time. And now every team in Bangalore are doing adaptive now, so they are getting stretched. So when we need them the most, they are not available. So that becomes an important challenge. Another thing is local field potentials, LFPs, beta oscillations are the only indicator of only the, bradykinesia and only thing. It's a gate freezing, and it doesn't substitute your clinical examination, clinical assessments. So I think monopolar review is still the gold standard. I think we still do that. And we still don't have a where you can do away without that and then depend on that. If be it image guided programming or thing. So your time gets extended. So I think time is the challenge for me.
I would go with same thing.
Recently there's a paper in MDS. They have done a large study. They author themselves have written a letter to the editor. That is the adaptive DBS, we have faced a mixed response. Not everybody will be benefited.
So I think, for me, adapting the adaptive DBS is more is lack of, there are so many unknowns. I don't know, for instance, when the study is done, they have been using that for so many years in the sort of hospital setting. For us, it is entirely new. What is the ideal threshold? What is the ideal stimulation? What is the range? Which patient to go for? What is, there are so many, even after so many years of continuous DBS, we are still sort of not, nobody can say I am 100% sure about this. At least I cannot say I am 100% sure about this. Even after that, there are always uncertainties that I don't know how to tackle this particular sort of complications or challenges.
Absolutely.
With adaptive DBS, that is again, whenever a patient is doing well on continuous DBS, there is milder change. So I'm not sure with the knowledge that I have, will we be able to provide a better response to the patient as of today? So with time, definitely the learning curve, maybe I'll be more confident. And the problem is, we try it, we see no response, maybe because of our lack of this one, and we say, okay, it never helped for us, so we'll have that negative bias also, that okay, I tried for 10 patients, it didn't work, why to waste that time again, we'll just continue with this one. So maybe for me, the major issues, apart from the time, definitely, there is no doubt about that. Lot of things explaining the patient how to do it and getting the timeline, calling them back and again checking. So that is definitely added sort of hindrance. Above that, my sort of difficulty in understanding certain aspects is also a sort of hindrance.
Yes,
on a lighter note, it's also the change in programmers, sir. For everything, they want a new programmer.
Yeah.
That old programmer which we bought 2 years back is
it's not
redundant
working.
now.
Yeah.
And with 4 patients coming, I'm stuck. I'm telling them, give me new programmer, otherwise I cannot put more patients.
Yeah.
Adaptive.
True. So I think I would say if patient is doing good in conventional DBS settings,
better not to touch
better
it.
not to touch. Or not doing, just trial and error. You see how it goes.
And patient feedback is very important. I have this patient, same patient, when we set up, adaptive, after 1 week or 2 weeks, is doing very well, tremor well controlled thing. Then he came and told that I'm getting palpitations during So one good thing is also looking at the sleep. What they also, advantage of doing adaptive is also looking at their sleep pattern and things. So he was complaining of palpitations and all. So, it took a while before you understand. Then I think it was probably he was getting off in the middle of the night, early mornings. So that was probably driving his non-motor symptoms of palpitation, sweating and all. So then we reduced his lower threshold. So it was probably, he was getting into off state in the night. So we reset the thresholds, it worked. The same patient now, he was getting cramps, in the one leg, which is most affected leg. Like clinician, we also do general neurology and all. We said, no, it is thyroid related and we corrected everything, but still getting cramps. Then we have to look at mostly it is, either dystonic or, probably capsular. So we changed from adaptive because they can't come every time to the hospital for adjusting. So we changed to conventional with a lower current. So it worked. So probably the threshold was probably higher. The amplitude was higher. The higher limit, and the current was going up. So probably. So the message is we also need to look at not only just thresholds. So like that slide what Mr. Dr. Vaidyanathan put, you need to look whether it is it is sensing well or not. If it is sensing well or not, then you go to the thing. If it is sensing well, then you go to look at the limits, the amplitude limits, the stimulation limits. So you need to look at both. So there are 4 variables. You look at thresholds, upper threshold, lower threshold, then the limits. So what we did in this patient is we reduced the amplitude limit, maximum limit. So then it worked. So if you keep a wider, like you said, you keep a wider thing, so that the ramping happens up and down too much. Then he used to get in the night what is not required. He was getting higher current, and then he was getting cramps. So that changed. So I think the data during sleep is also very important. That's a very vital thing which gives us from adaptive.
Any questions from the audience?
Postprandial, I think some more.
Thank you.
And first of all, thanks to the neurosurgeons. No, they wanted the session earlier, but we had the opportunity to go and have our lunch. Thank you.
You also told that you will keep some continuous stimulation at one point, and only if the beta activity changes, the fluctuations happen. But why do you see so much of on and off in patients with adaptive DBS then? Because you have a constant voltage which is going on in the background.
No, I didn't understand the question. Can you?
You said with adaptive DBS, there will be a lot of fluctuations for the patients. Clinically, there are a lot of fluctuations?
No, not that way. What I'm saying is, if you keep the limit, there are two things. There is a threshold, LFP threshold, upper threshold, and there is a LFP lower threshold. And there is a current upper limit, lower limit. So idea is to sometimes keep, what they say is you keep the amplitude at certain, and there is +4, -4. But that +4 is little bit higher. Like for example, you kept 4 milliamperes, and then the upper current threshold or limit is 4.4. And if it is in the night, for this patient, it is going up at 4.4, then he is giving side effects, which is not happening in the daytime. I'm not able to explain everything, but simple thing is to reduce the thing. So keep it at 3.6 or something, even if it goes up to 4, that whatever the dystonia or whatever having the painful things reduced. So that was the idea.
That point was, I think if you pause the aDBS, then it gets fixed at that pause voltage. Okay.
If you don't pause, it keeps
fluctuating. That's the whole purpose.
If you pause, it is worse than a conventional because you cannot increase or decrease. So if you pause aDBS, then better switch to the conventional. Actually.
Yeah. So that's what we did. Before he came, we switched out to conventional. He was okay. Then when he came, we reset the amplitude limits. Then he was better.
Just one question about the pause, because unlike continuous DBS where there's a patient programmer and you have set limits and they can increase and decrease at home, in adaptive the patient doesn't have any control. So the pause amplitude actually works like a safety in case it's not feeling right. You go to the most optimal previous continuous DBS setting. So they can at least be on that and then they come to you for their final tweak, right?
Correct.
Yeah.
I request Dr. Nishchit to hand over the mementos to the panelist here. Dr. Guru Prasad, sir. Dr. Anish. Thank you. Thank you. Ajay, vote of thanks. Yeah. Yes. Come, Swati, come. Dr. Kuldeep, please come. Sorry. Yeah. Dr. Satvik, please come. One moment to Dr. Satvik also.
A very lean crowd. At the outset from Manipal Hospital Sarjapur Road, I would thank all of you for coming to this event. I mean, not many people left. So thank you all. And whoever have not had lunch will break for lunch now.